Can we start?
Respected President Professor Anand Kumar, Chairman Indian School of Urology Dr. Rajiv Sood, Co-Chairman Dr. Arun Chawla, esteemed international faculties, Guliographer Ranjit Ramaswamy, esteemed faculties from India, viewers from Urological Society of India and SAARC countries. I, on behalf of the Council of USI and Indian School of Urology, welcome you all to this webinar on practical lessons in endourology. Today, the moderator, Dr. K.V. Vinod, has compiled an excellent program, and we have an excellent panel of faculties here to give, to enlighten you on various aspects and to take forward your question and answers. With this, I welcome you all to today's USI ISU webinar on updates in endourology. Now I request the President, USI, Professor Anand Kumar, to give his address. Over to you.
Good evening to everybody. Good evening to Rajiv, Dr. Rajiv TP and Dr. Rajiv Sood, Dr. Chawla, and all the national and international participants, all the faculty and USI members and delegates. Welcome to all. This is a very important webinar, and this is andrology, and which is very close to the heart of all andrologists. And you see most of the andrologists, when they write their designation, they write urologist and andrologist. So that is, and they feel very pride to announce that they are andrologists. And since the andrology is practiced by the urologist as well as the gynecologist, there is a tussle between two, and there is a very healthy tussle. And I have seen some of the gynecologists are very aggressive and doing the most of the male part of the andrology also. And so it is very important to keep this andrology into the field of urology. And we have many very good andrologists in USI, and I have seen during USI conference, there is attendance in andrology workshops is very high, and so there is a lot of interest, and a lot of people are interested to do that. And so this webinar is very appropriate in this regard to update the knowledge of the andrology by our experts. And I'm very happy that there will be large number of people will be participating and benefiting from this webinar. Though I don't practice andrology, but I would like to listen to it, because people come and ask at least questions, so I should not look stupid for not giving them right answers. So with this, as a president of USI, I would like to pray for the good health of all my members, all the delegates, all the participants and their families. And I wish them good health, stay healthy, and please do not lower guard. Take all precautions so that you may not get infected and serve the humanity. With this, I welcome you all for this very important webinar, andrology. So back to Dr. Chawla.
Over to you, Dr. Rajiv Sood. Dr. Rajiv Sood, sir.
Okay. Good evening. As our president, Dr. Anant Kumar has just mentioned that andrology is very importantly and close to heart to many of our urologists, or rather majority of the urologists. Andrology, the interest started in USI especially around 2-3 decades back, when our Dr. Rupin Shah, Dr. Vasan, there were some of the stalwarts, they started work in andrology, and people were not understanding that what is andrology. They were confusing it with the endourology. So it took time, and now we are on a different platform. We are with the national, international faculty interacting in our teaching and skill upgradation webinar, seminars, webinars, workshops, and there are stalwarts who had been doing marvelous work in this important branch and in the cell-based functioning of USI. We have andrology as the important subject. Dr. Anant Kumar mentioned that he is not doing much of andrology, but Dr. Anant Kumar, prostate is the most important organ other than penis and hormones. That is in andrology, and you are very well doing andrology very actively. And therefore, when we talk about infertility, hypogonadism, and also other aspects, this is the most important, because when we talk about nephrology, the opposite is urology. When we talk about gynecology, opposite is the female side of that is, and then the male side is andrology. And today, this topic is very important as we are touching some aspects on hormones also. And hormones have become very, very important in this COVID era. And we all know many experiments, many trials are concluded, initial studies and going on, that hormones have important role, especially testosterone and also progesterone and estrogens in the management of COVID. And that is very important aspect which is coming. And in Japanese studies and other US studies, this has been now amply proved that if you lower the hormones, then we can fight COVID better, like androgens. But we are talking about hypogonadism. So one important aspect is that in this era, when we are treating hypogonadism, we are giving testosterone, how safe it is in the era of COVID management. That is also emerging as very important aspect. So coming back to the academic aspect of this webinar, this is very important webinar in our series, and we will be deliberating on this important issue in the contemporary scenario also. We will be, I hope that all the presenters and with the international faculty, when they are interacting, they will take care that how our practice is in the contemporary scenario, because we are living in the new normal now. This is new normal for our associations, for our clinic management, institutional management, for our hormonal management, and also our operations and all. So how we are coping up with this, and I thank Dr. Ranjit and Dr. Grafa to join us from international faculty, and also Rupin, Vasan, Hota, Shivam, Dr. Vineet, and Raman also. And along with that, Dr. Vinod is to be congratulated for crafting this program. Wish all of us very best for the success of today's program. Thank you.
Thank you, sir.
You have to unmute yourself. You are muted, Dr. Rajiv.
Thank you, Professor Sood, for your enlightening words. Now I request moderator Dr. K.V. Vinod to take over the session. Over to you, Vinod.
Vinod?
So, yeah, I'm here.
Yeah.
So what we are planning is we have divided the topics into two sections. One is the erectile dysfunction and the other one is the male infertility. Almost 2 hours we'll be discussing on in both sections, almost equal division. And what we are planning is there will be a discussion for a session will be completed, and at the end of the session we will be taking up questions. And those viewers who are seeing the webinar through YouTube can access it, can give their questions to the chat box, and the faculty will be answering it if possible right then and there. And some of the questions will be picked up or selected depending on the nature of the questions, and it will be discussed at the end of the session. And after each session, we will move on to the next session. That is how the whole webinar is planned. And towards the end, if we are not able to answer all the questions, I will provide the WhatsApp number and the email ID to which you can send your questions. And these questions will be answered by the faculty, and it will be sent back to them over mail or their WhatsApp. So we will be trying to take up all the questions as far as possible, and we are planning to give you all the discussions in a very focused manner, which will help those who are interested in the andrology subspecialty. Now, first of all, I invite Dr. Vasan for a discussion on early diagnosis and interventions in hypogonadism. Dr. Vasan, sir.
Yeah. I hope everybody can see the screen. Is it clear?
It is visible. It is visible.
Yeah. Thank you, USI. Thank you, School of Urology and Vinod, for giving this opportunity. I made this because this is a very difficult topic, basically because we are looking at what the urologist can do for an early diagnosis and intervention in hypogonadism. So I have confined this more from the clinical arena. So, as we all know, the fetal pituitary has this SRY gene complex, and we are all aware of this. Some of this I'm going to rush through because these are basically embryological phenomena which most of you are aware of. And we know that there is a significant role played by the fetal testis in terms of Sertoli cell and Leydig cell activation, and also testosterone and AMH. So consequent to this, if there is an abnormality at the level of the fetal testis, then you are looking at, fetal androgen deficiency. And then you have, at that point in time, you could have microcephalus or ambiguous genitalia in the form of cryptorchidism, bifid scrotum, or pseudovagina and whatnot and so forth. So this is at the fetal level. So the next is, what are we talking about? What we are talking about male hypogonadism. We are looking at focus is predominantly on growth in boys. So consequently, how do we define male hypogonadism? It's either a decrease in the production of testosterone, or it's a decrease in the production of sperm, which we don't know till the person reaches adrenarche, or it could be a decrease in the production of both, or it could be a decreased response to testosterone, resulting in delayed puberty and reproductive insufficiency, or both. So what happens because of this is, in boys with hypogonadism, there is a slow muscle and genital development. Arms and legs are long in relation to their torso. Body hair is sparse. Voice does not deepen. And that is the clinical scenario which presents. So how do we go about identifying those boys who require treatment? That's the big challenge. What age we intervene? And Vinod had given me some focus areas which I'm going to concentrate on. Broadly, the classification is either primary or secondary, or there is another type which is caused by defective androgen action, which is primarily due to defective androgen receptor activity. So these are the broad classifications. The funny aspect is, either it is primary or if it is secondary, both cause androgen deficiency with impaired sperm production. Though in the primary, the sperm production impairment is more than in the secondary, the testosterone impairment is less in the primary and more in the secondary. So that's the broad classification. The critical point is hypogonadism. Why are we concerned about? Because we know that physiological transition from childhood to reproductive maturity is associated with a growth spurt, appearance of both primary and secondary sexual characters in children, and this generally occurs between the ages of 9 and 14 years in boys. So what are the pre-pubertal manifestations? You will have a small testis, phallus, and a prostate, which is infantile, scant pubic and axillary hair, disproportionately long arms and legs from delayed epiphyseal closure, reduced male musculature, gynecomastia, and persistently high-pitched voice. This is what is the pre-pubertal manifestation. However, in terms of post-pubertal manifestation, you will have reduced sexual desire and activity, decreased spontaneous erections, loss of body hair and reduced frequency of shaving, infertility, reduced bulk and strength, hot flushes and sweats, height loss due to atraumatic fracture, small or shrinking testis, breast enlargement and tenderness. So these are post-pubertal manifestations. In fact, post-pubertal manifestations are more classical and easier to diagnose. The challenge for the urologist is always been pre-pubertal, because in terms of physical changes, there are 5 changes from childhood to full maturity, which is your Marshall and Tanner stages of P1 to P5, which reflect progression in changes of external genitalia and sexual hair. And this leads to secondary sexual characteristics. The mean age of this development is 11.5 to 12 years in boys. So how do we identify it? So the basic problem is the first signs often go unnoticed. Testicular enlargement starts between the age of 10 to 12 years. Pre-pubertal testis is approximately 2 ml in diameter or 2 cc in diameter. Puberty begins when the volume reaches about 4 ml. Penile and scrotal enlargement occur approximately 1 year after testicular enlargement. Pubic hair appears also at the same time. So in a patient with hypogonadism, the challenge has always been the apulsatile pattern of LH release and the sleep entrate pattern, decreased amplitude pattern. All these contribute to impaired reproductive and gonadal development in children. So the constitutional, one of the challenges has been, is it a constitutional delay in growth in puberty, which is what we call as CDGP, transient secondary hypogonadism, which is the primary cause in about 65% of people. And that is where the challenge is, because many people may feel it's a part of the constitutional delay and ignore, or the 35% which seriously have a problem may not be picked up. And consequently, the delayed puberty should be suspected if sexual maturation and testis size is less than 4 ml at 14 years of age. There is an increase in prevalence in families with idiopathic hypogonadotropic hypogonadism, which is also a variant. Height and age, etc. are important. So the basic challenge has been, we should have a proper evaluation system. So what are the key elements of a proper evaluation? The key elements is the parents' pubertal timing, late menarche in the mother or delayed completion of adult height in the father is strongly suggestive of constitutional delay of growth and puberty, which represents 65% of children. Family history of hypogonadism, autoimmune disorders, disorders of sexual development or consanguinity, CNS insult, symptoms of chronic disease, or we all know that Klinefelter, which is a primary problem in these groups, should be considered. So the key element of the history taking should be a full history of previous growth and development, record timing and sequence of the physical milestones and behavioral changes of puberty, full medical and surgical history. If underweight, take full nutritional history, family history of early or delayed puberty, family history of any genetic disease. The second aspect is the physical examination, where height and weight measurements by using growth charts should be done. Anticipated child height usually is height of the father plus height of the mother in centimeters divided by 2. So that is your norm to decide whether the child is falling in which percentile of growth. Assessment of secondary sexual characteristics include Tanner staging and recognition of evidence of androgen exposure. Testicular enlargement, which sometimes can go unnoticed by boys, indicates evidence of central puberty. Neurologic assessment of evaluation of visual fields, stigmata of Klinefelter syndrome or testicular dysgenesis should be noted. external genitalia should be visually inspected for any signs of abnormality. So these are the typical growth charts which are available, where both your height, basically we are concerned with height. Of course, weight is also taken in because malnutrition could cause a significant constitutional delay in growth patterns in boys. So consequently, so there are various types of delays which happen. One is, like I said, the constitutional delay, nutritional delay, GH deficiency delay, familial delay, or the Turner syndrome related delay. So you should keep broadly in this phenomena in mind when you're looking at it. The assessment of the second, what you need to do is plot height, weight, and BMI and growth velocity. Compare with old measurements if available. Examine all system, endocrine, neurology, like I said, optic fundi, visual field, sense of smell, genitalia, body habitat, stage of puberty. So the normative values are provided for testicular volume. These are all standard literature which is published, and you have the normative values which is available, and you can measure either by ultrasound or by Prader, orchidometer, which we use. And this is the normative values where you can know that if the testis is not growing beyond 4 cc, there is a delay in the puberty, because around puberty, the testis is around 4 cc. And this is what you concentrate on. Then you concentrate on penile length for age nomograms in prepubertal boys, where you have these nomograms for various ages. And again, you are looking at, by the age of 9 to 10, a penile standard length should be at least of about 5.2 centimeters. And that's what you are looking at. So the penile length for age nomograms is classified, and these are available, where you have the normal growth pattern, the higher growth pattern, the delay in constitutional growth, which is what gives you an idea whether the child is lagging behind. So, and we are all aware as urologists of Tanner scale for boys, which is in 4 stages, which essentially looks at the penile size, the testicular volume, and classifies these boys into 4 stages or 5 stages, where you can look at whether there is an average development which is happening in these boys. So normal pubertal development has these 4 components. One is the height velocity, which you need to track, the testicular volume, the genital development or the penile size development, and the pubic hair. And we all know that this starts between the 10th to the 12th year, and consequently that is the age where you should watch out for. So the pubertal delay, what is called as a pubertal delay, is based when there is a statistical delay, or there is more than 2 standard norm deviation, which is the population mean. And this is more often seen in males, and that's why there is a channel. And this also delay causes significant psychological implication. Most commonly, like I said, it is because of constitutional delay and no pathology may be present. So the timing of puberty is usually, if you consider it as a pubertal delay, if the testicular size is less than 2.5 centimeter or 4 ml, or pubic hair is not present in by age in a 14 years in a male, it is considered precautious if the testis volume is more than 3 ml before 9 years of age. So this is the pubertal delay, where if you suspect a delay, you are looking at hypogonadotropic hypogonadism, or hypogonadotropic hypogonadism, or eugonadotropic hypogonadism. So pubertal delay happens because of constitutional delay of growth and puberty in 63%, delay because of an associated underlying medical condition in 20%, hypogonadotropic hypogonadism in 9%, hypogonadotropic hypogonadism in about 7%. So what do? The laboratory evaluation is estradiol and testosterone. Low gonadotropin levels suggest CDGP or pathologic hypogonadotropic hypogonadism. There is no importance to TE ratio at this point in time. And of course, you can do advanced tests for GnRH stimulation and other things, which, if it is necessary, depending on the individual situation, you decide. So this is the rough algorithm, which is more applicable to post-pubertal boys or adult men, where we are familiar with this algorithm of testosterone testing and its implication. So constitutional delay of puberty, how do you recognize this? Progressive height gain, but along the lower limits of normal. Contrast to isolated gonadotropin deficiency, which has normal growth, but no pubertal spurt. Early morning testosterone levels of more than 0.7 nanomoles per liter predict puberty within 15 months. And this is a very important characteristic where we can understand whether this child is going to achieve puberty. So the treatment is predominantly, the goal is to stimulate normal progression of pubertal development that also allows for attainment of genetic potential for height. That is the goal. And the therapy is usually HCG, 1000 to 2000 international units intramuscularly, 2 or 3 times a week. This should be titrated. Initially, we give it only once a week or once in 2 weeks to see the response, and then we decide. Role of testosterone is only in post-pubertal, hypergonadotropic, or when you feel that the testicular size is very small and you want to use it as a short stimulant. But you should always follow it up with physical examination charts. Testosterone levels should be monitored monthly. It may take 2 to 3 months to achieve normal levels of testosterone. When normal levels of testosterone are reached, check monthly to determine if there is any corresponding testicular growth. So these were the case scenarios which Vinod had given me. I'll just summarize my lecture in the next 1.5 minutes. This is a case which Vinod gave me, which is 18-year-old boy, X-ray shows puberty, thyroid test seems to be normal, celiac screen, CBC normal, poorly developed secondary sexual characters, 3 ml test is bilaterally, had visited GP at 10 to 12 years, reassured, lost to follow. This is a typical case of late presentation of hypergonadotropic hypogonadism, because a 3 ml test is having poorly secondary sexual characters is very unlikely. Hypergonadotropic hypogonadism usually has normal testosterone level. So this is a contradictory feature which I cannot explain. This was a case scenario which was given to me. But essentially, when you're looking at a 3cc testis, you pretty much know that there is hardly any gonadotrophin, or the testicular development is poor, and you're looking at gonadotrophin, which is abnormal. The earliest age to pick up hypogonadism in a child is around 10 years. Some people debate it at 12 years. Earliest manifestation and the role of screening is usually at 10 to 12 years. Role of parents, and role of primary care physician, all of them need to understand there's a lot of counseling which is required, education of growth charts, expected height to be explained, and role of nutrition cannot be underemphasized. Then identifying hypogonadism at an early, what are the clinical and lab indicators? Difficult to answer, but one of the guidelines we have at this point in time is early morning testosterone levels of more than 0.7 nanomoles per liter, which is what is needed by the age of 10 to 12 years for the child to achieve puberty. Role of endocrinology in treatment, how often we need endocrinology help, what if no consultation is done? Only if the clinical condition is suspected to be the cause. If it is CDGP, there is no need, the urologist can manage. If hypo or hyper, no need. Only if there are other conditions which you suspect and you want to go in for advanced testing, then there is a role for an endocrinologist. How to treat and follow up hypogonadism? Medical therapy for hypogonadism, earliest stage to start treatment if index of suspicion is high on the basis of whatever evaluation I've told you. HCG, lowest dose 1000 units. Like I said, you can start once in 15 days, once in a month to see the response. Monitor testosterone, growth charts, testicular size, penile size, total development, but always watch out for excessive virilization. Follow-up schedule and maintenance compliance, monthly initially till dose titration is done and stable hormones. Growth pace to be gradual. You don't want to over-androgenize to ensure gradual growth to anticipated Tanner stage by 15 years. That is the goal, and one stable once in 3 months. Thank you very much, ladies and gentlemen. I hope I've been able to cover whatever I was asked by Vinod and the USI Council to cover. Thank you very much.
Can you, thank you, Dr. Vasan. Can you stop sharing the screen, sir?
Hello, come again?
Yeah, can you stop sharing the screen?
Yeah, sure.
So we have seen what is happening for a child with hypogonadism, how to pick up it early. And now we are going to a common scenario in infertility, where you have a patient with azoospermia, most probably non-obstructive azoospermia, and the infertilologist or the male infertility specialist andrologist will suggest for an ICSI, and people will start roaming around and asking for what is the prognostication, what is the chance that I'm going to have a baby. So Dr. Vineet is very much in the practice of andrology, and he'll be explaining to us how he is going to prognosticate the sperm retrieval rates in such a case, and how he is planning to improve the sperm yield in such a patient who is planning for it. Dr. Vineet, over to you.
Thank you, Dr. Vinod. I would also like to thank Dr. T.P. Rajiv and Dr. Anand Kumar for this opportunity. And we'll quickly begin because I think this is going to be more like a sprint rather than a marathon. So we're talking about prognostication of sperm retrieval rates and whether there are any ways that we can improve this. Yeah. So the case given to me was a 32-year-old gentleman whose partner is normal, has non-obstructive azoospermia, planned for an ICSI, and has come to you for a second opinion. And before I go on to the case, I have a question for the audience, and keep this in mind and see if you have an answer to it, and we'll see if we can reach an answer to this. If you were allowed one test for this patient prior to taking a decision regarding sperm retrieval, what test would you do? So keep in mind, you've been allowed only one test for this patient who has non-obstructive azoospermia. What would it be that you would want to do before you would go ahead with surgical sperm retrieval? Now, when we go into the etiology of non-obstructive azoospermia and we're talking about sperm retrieval, or we're talking about reversibility of the condition, we know hypogonadotropic hypogonadism is very, very favorable. This is actually the only one which is proven medically to respond to therapy. And we will not be focusing on hypogonadotropic hypogonadism. We will instead be focusing on my case, which probably deals with eugonadal or hypogonadotropic hypogonadism, which may also be congenital or acquired and may have genetic reasons such as Klinefelter's, or be a result of varicocele, cryptorchidism, trauma, torsion. A large percentage, 15% of these can be idiopathic. So this we've already said, and we are actually going to search for the not very simple answers that come into the hypergonadotropic or eugonadotropic range. What can be the prognostic indicator? So when we talk about this, we have to consider what the primary disease is. Is it related to hypogonadotropic hypogonadism? Is it reversible, modifiable? Are there congenital factors related? What is the paternal age? Now, this is going to be important for two considerations. If the age is borderline, where you're looking at paternal and maternal age being less likely to be suggestive of conservative methods, you are less likely to suggest medical therapy, because this is going to be something which is going to be a prolonged medical therapy. With hypogonadotropic hypogonadism, you're looking at a year at least, or maybe some years, and you may not have that kind of time. So paternal age, apart from having a direct factor related to spermatogenesis, may also be related to other factors. Testicular volume, which is another possible indicator. What is the hormonal status? The FSH, inhibin B, which is spoken about a lot, and the testosterone and the testosterone estradiol ratio. Genetic abnormalities, and the histopathology if this is available. So we'll quickly talk about each of these, but understand that there are rate limiting factors to prognostication. And why is that? When we look at testicular volume, something as simple as testicular volume, we have no standardization for this. A Prader oximeter is not used at most clinics, and even otherwise there is a subjective variation in terms of assessment of testicular volume. FSH is different lab thresholds, different criteria for measurement. We have limited data for certain parameters such as paternal age, inhibin B. We don't have sufficient data. And then there is the question mark of the cyclical variation in sperm production, and that could also affect the data that we get, because there is a question mark that's been put on what part or what timing of the cycle did you assess a particular patient at. This is one study which I would want all of you to go through if you're interested in knowing about this. This is a recent meta-analysis. In fact, it is only available online right now because this is a June 2020 issue. And I have also not got a hard copy of this, but this is excellent for us because it talks about prediction based on paternal age, Klinefelter's, cryptorchidism, FSH, inhibin B, the technique that is used for surgical sperm retrieval, and whether adjuvant medical or therapy or varicocelectomy will help in these cases. So we'll begin with the Klinefelters because that's the commonest genetic abnormality which is associated with non-obstructive azoospermia. And there's conflicting data here. We've had studies which have reported 65% retrieval rates, and we've had studies which have reported 20% retrieval rate. Our experience has also been conservative. And if you look at a very, very large study, the reason to identify this is that you would not refuse a patient for surgical sperm retrieval even with Klinefelters. And there's enough data to show that you have surgical sperm retrieval in patients with Klinefelters. And this is the meta-analysis by Corona et al., which is actually shown. Actually, it compared parameters of age, testicular volume, and hormonal status also in these patients, and we'll talk about that later. But it's possible for men with very, very small volume testes with very high FSH to still harbor focal spermatogenesis, and so SSR or surgical sperm retrieval is not precluded in these patients, is not excluded. It's independent of age, testicular volume, and hormonal status. There is data to show that the retrieval rate in men with Klinefelters is lower if the man with non-obstructive did not have Klinefelters. So that's the conflicting data that we get. The second most common genetic abnormality is a YQ microdeletion. And here we find that if you have a AZF A or B deletion, then there's an extremely low to zero possibility of sperm retrieval. Whereas if you have a AZF C region YQ microdeletion, then the sperm retrieval exceeds 50%, even up to 55%. And therefore, there should be counseling for these patients accordingly. And this genetic testing is mandatory before a patient undergoes a surgical sperm retrieval. What about paternal age? Again, we've already studied the meta-analysis presented by Corona et al., which was 21,000 patients, and they did not find any significant difference in outcomes for older men. We've got variable data. We have some studies which have shown that men above 50 have reduced surgical sperm retrieval rates. But if you look at the larger meta-analysis that we have, they've not found any significant difference in spite of increasing paternal age. What about testicular volume? This is something which has been discussed long. If we look at a study which was presented by Bryson et al., where he divided the testicular volume of men into 3 groups, that less than 2 ml, 2 to 10 ml, and more than 10 ml, they found no significant difference in the sperm retrieval rates in these men. And again, there is conflicting data. We've got some data which shows that if the testicular volume exceeds 12.5 ml, there is higher sperm retrieval rate. But currently, based on all data available, we cannot recommend no surgical extraction based on small testicular volume. In fact, we find sperms in smaller testes fairly frequently. What about FSH? FSH itself also has been found to have no correlation with predicting surgical sperm retrievability or presence of spermatogenesis. And again, one of our co-panelists today, Ranjit Ramasamy, had this very interesting paper where they had 4 groups of FSH less than 15, 15 to 35, 3 groups, 15 to 35 and 35 to 45 and greater than 45, and found no difference in the surgical sperm retrieval rates. In fact, in the group 2 and 4, they had higher sperm retrieval rates than in the group which had an FSH of less than 15. So what was then recommended was that FSH essentially indicates a global testicular function. It does not tell us whether there is presence or absence of focal spermatogenesis. So based on FSH alone, we can't predict whether sperms will be present and whether we'll find them on retrieval or not. What about inhibin B? Inhibin B has been spoken about a lot. Inhibin B in conjunction with FSH has also been studied, but conflicting data. Several studies which have shown positive correlation, several which haven't, and the data currently does not recommend inhibin B to subscribe whether or not a patient should undergo surgical sperm retrieval or not. What if the patient has a testicular histopathology available? And this has been interesting because testicular histopathology can actually tell us whether there is any chance of harboring sperms or not with a reasonable degree of accuracy. However, it's not recommended to be used as a diagnostic modality before a surgical sperm retrieval effort because one, there is likely to be damage to the testes, and secondly, you may not find the sperms that you found in the first instance again. Hypospermatogenesis, late maturation arrest are associated with higher sperm retrieval rates. Sertoli cell only is associated with a low sperm retrieval rate. However, no patient can be excluded based on prior histopathology. So you can only predict the recoverability, you can counsel the patients, you cannot exclude patients based on histopathology. What about surgical technique? You're kind of finding the needle in the haystack. And we have data here. In fact, this data is interesting because for a long time there were a lot of studies which tried to show that conventional TSA actually had equivalent rates to micro TSA. And if you look at this meta-analysis by Corona et al., the pooled estimates actually also showed the same thing. They showed no difference between sperm retrieval rates between the conventional and the micro TSA. But when they actually compared these two procedures head-on, there was a significant difference in retrieval in the men that underwent a micro TSA procedure. So as soon as it became possible to use micro TSA, the idea of testicular volume, the idea of things which allowed a conventional TSA actually became irrelevant. There are other ways which have been suggested now and are being attempted to improve the outcomes of a micro TSA. And there is a recent paper from Turkey which talks about MR spectroscopy. There's been multiphoton microscopy, testicular color duplex ultrasound, and a variety of techniques, laser, which have been used to attempt to improve the success of a micro TSA. None of these are current standards, and hence a standard micro TSA is the procedure of choice for surgical sperm retrieval. Can we modify the sperm retrieval in non-obstructive azoospermics by any method? So there have been two things which have known to modify or have been used or attempted to modify the outcomes in surgical sperm retrieval in these men. And there's been use of adjuvant medical therapy or varicocelectomy in men with varicocele and non-obstructive azoospermia. We have a lot of data here. In fact, Ranjit has published a study in men with Klinefelters, and there is this very large prospective cohort, which is, this was a very important prospective cohort presented by Shireshi, where they actually gave high dose HCG. And they had men who failed micro TSA in the first attempt and then repeated the procedure after 6 months, and had men who, almost 20% of men that then had sperms in their retrievals specimens. So this was a paper which actually presented sperms being found after medical therapy. There's another one which was by Hossain et al. Overall, this is very controversial. Unfortunately, it's extremely abused form of therapy. The data is limited. We have few studies. We don't have so many studies to prove that you can use adjuvant medical therapy to benefit. When will you attempt to use it? So is there a group of men that you would actually recommend this to? Yes, there is some evidence, weak though, for use in hypogonadal men where the pre-treatment total testosterone is less than 300 nanograms per deciliter. So there you may use it and bring the testosterone to a target level of about 500 to 600 and then proceed.
Can we wind up fast?
Yeah,
I'll just slightly putting it back.
So the idea is that this can be used as one of the methods. Adjuvant varicocelectomy is also known to improve the sperm retrieval rates in men with non-obstructive azoospermia, sometimes even with semen in the ejaculate. So coming back to the index case that we had, what would you option? And so the answer here is that you would have to do genetic testing for YQ microdeletion. You could or could not do a karyotyping. You would look at varicocele, whether it's present total testosterone pre-treatment, and end up advising micro TSA oblique donor sperm for this patient. So what would be the practice pointers for a man with non-obstructive azoospermia? The only condition which tells us that we should not use any surgical sperm retrieval procedure is if he has YQ microdeletion with AZF A or B. In all other cases, surgical sperm retrieval is possible. There is lower success rate with Sertoli-cell only or Klinefelters. Adjuvant therapy may be beneficial for a few hypogonadal men. Large varicocele may respond to surgery, especially with a better surgical sperm retrieval rate. And age, testicular volume, hormonal status, all of these are not correlated. I would recommend everyone to read this paper by my mentor and guide, Dr. Rupin, which also talks about sperm retrievals and their prognosticators in this excellent article. And a lot of times, just pure luck when you get these sperms and nothing else. Thank you so much for your kind attention.
Thank you, Dr. Vineet, for this excellent talk, especially covering the intricacies of the prognostication path and its treatment. Now, we all know that varicocele is the commonest surgery done by a infertility specialist, and it is done by not only by urologists and so many other people. So, failed varicocelectomy has been a concern for years, even for andrologists and as well as for the gynecologists and the infertility specialists. Dr. Raman will be discussing in detail about how he is going to approach a patient with a failed varicocelectomy. Dr. Raman, on to you.
Thank you, Dr. Vinod, and thank you to ISU and USI, all the dignitaries. I welcome all the audience here. A very good evening. And today we're going to discuss something about a very difficult topic, I would say, something that makes the andrologist's heart racing when they get a case of a failed varicocele repair, especially if it has been done by them. To begin this topic, let's start with the index case. Let's understand what a typical patient presents with. So here's a 28-year-old gentleman. He presented with secondary infertility. There has been a history of an abortion earlier. And he had bilateral varicocelectomy. It was an inguinal open surgery done for obstructive azoospermia, for obstructive teratoasthenospermia 2 years back. And now when he has come back to you, he has a grade 2 varicocele on his left side. And when you do look at the semen analysis, it shows that there is severe oats again. So this is a poor chap who has, who has been unsatisfied with the surgery. But since we're looking at just a few lines here, we're not really looking at the patient. So there are many other things that we have to look into when we are discussing such an index case. So these findings, maybe what are the examination findings look like? Is there some tenderness in the epididymis? That's what I commonly, find a lot of patients of these types have MAGI, which is male accessory gland infection. And what were the semen parameters like before surgery? And then you also question whether the varicose repair was even indicated. And did they do more damage than good? So all these questions, they would depend on actually seeing the patient. But taking it forward, what are the various variabilities or possibilities which could affect this kind of a case? One is the indication for which the surgery was done. So as we know, in this case, it was infertility for which the surgery was done. But then there can be a lot of indications for which we do varicocele repair day in, day out. It could be infertility, it could be pain, it could be reduction in the testicular size. It could be just cosmetic reason that patient is concerned about the veins being ligated, being so enlarged and tortuous. It could be hypogonadism, which is setting in. So this is also something which we do not take into account, but this is one of the recognized indications. And in India, very commonly, we have the medical exam, which leads the patient to an andrologist or a surgeon or a urologist to do the surgery. And then we have to look into who did the surgery. Was it a surgeon who did the surgery? Was it a urologist who doesn't commonly do the surgery but still did it because it came to him anyway? Was it an andrologist who's been doing it and did it, or was it an equipped andrologist? So there's a difference between an andrologist and an equipped andrologist. They are, because we'll be talking about how technology is making a difference in the outcomes of varicocele treatment. And then we will also want to know if there were any complications. Were the skills not there? Was there a previous surgery that had been done? Were there some technical challenges with the armamentarium? And we also need to look at, before we call this a varicocele failure, whether this is oats because of some other cause, because I highly doubt that a unilateral grade 2 varicocele would be causing severe oligoasthenoteratozoospermia in this patient. So Is it male accessory gland infection which is causing this? Is this an oxidative stress? Is it an idiopathic cause? Is it a testicular cause? And actually, is it there due to varicocele after all? So in this talk, giving this background, we would like to just go to the overview of this talk on failed varicocelectomy. So first we will talk about what is a failed varicocele repair. What is the real versus the pseudo failure, because this is a new term and we are introducing more new terms in this talk. And why does the repair fail? What are the patient anatomical factors? What are the factors in the surgical technique? How to minimize this failure repair through methodology, through skills, through the way armamentarium which is available but is not being used. And once when we find that it's a real failure, how do you take care of those situations?
Raman, audio is not there.
Is there any problem from Raman's side?
Probably the connection is off.
I think connection is the problem.
Okay.
We know we
He's
can.
managing it. He's managing it. He just texted me that he will come back. If he's not coming back in 30 seconds, I think he will move to Dr. Rajiv Tipi and he will continue to present, and at the end we can take up Raman.
Navneet, if you can call and find out what is happening.
Yes, sir. I am already on it, sir.
Yeah, thank you.
Dr. Ranjit, you are ready. If in case you have to present, you are ready with the slides, right?
Yeah, I'm ready. Yeah.
Yeah.
I think we can carry forward with Ranjit.
Yeah. Okay.
And, join later.
Now I think we will go on to Dr. Ranjit Ramasamy. He has accepted our invitation to be part of this webinar. In spite of his busy schedules, he's a very busy andrologist in US. There's a lot of publications and there's no introduction needed for him. And he'll be talking us about the present status of microteasing. It is a key thing in andrology. Over to Ranjit.
Well, thanks so much for the opportunity, Vinod, and thanks so much to USI for hosting this webinar. The goal for today is to talk about microteasy. I think there was a very nice introduction early on about introduction to a case, how do you deal with non-obstructive azoospermia, and what we can do to best improve their chances of sperm retrieval. I've obviously shared the stage with Rupin and Vineet for many years now. Rupin can sometimes be father of andrology in India, truly started the field and certainly has trained so many people that are here on this webinar to share this stage with him. Certainly this was in Mumbai, this was in Cambodia, and then now we have a lot of youngsters trying to do andrology, and that's very nice to see that the field has grown so much in the last decade in India. So we'll start off with a case. It's a 33-year-old guy with a 31-year-old healthy wife. He's azoospermic, very small testes, 4 cc testis volume. You do a hormonal evaluation. His testosterone is actually on the low side, but still normal. His LH is 5. His FSH is increased at 15. His prolactin is normal, and his estradiol level is also normal. So one of the first things you want to do is you want to figure out why this patient is azoospermic. And it's either due to a production defect in the sperm or it's an obstructive defect. And that's the first thing you want to do. And based on a very nice paper from Niederberger back in 2002, I think we're all very familiar that both FSH and testis size are probably what determine whether this is a production defect or an obstruction defect. So I think in patients with very high FSH, this patient had 15 FSH and the normal was 8 in the lab, and very small testes, so 4 cc testes, I think we should all be almost certain that this is azoospermia due to a production defect. There's absolutely no evidence for a blockage. And so when you look at azoospermia due to production defect, the underlying histologies can be three. And this is where the distinction is, where this could be the most prevalent histology within the testis. So it could either be Sertoli cell only syndrome, where there is absolutely no germ cells at all. There could be maturation arrest, where germ cells keep progressing through meiosis but get arrested at some stage. And then hypospermatogenesis, where there are small foci of spermatogenesis and sperm production within the testis, but that's certainly not present throughout the testis. And I think with microdissection, I mean, anytime you see a pathology report and says Sertoli cell only or maturation arrest, it is very easy to tell the patient and the couple, listen, you have no chance of finding sperm in you. You have no chance of having a biological child. And I think that is incorrect based on a diagnostic biopsy report. And anytime you see diagnostic biopsy reports, that actually indicates the most prevalent histology within the testis, but certainly not the most advanced histology within the testis, which is what we are trying to find whenever you're doing a microdissection. Very nice study with Dr. Schlegel that we did back in 2007 that shows that even in patients with Sertoli cell only histology, up to 1/2 patients can have rare foci of sperm production within the testis. And obviously, if you keep doing more and more diagnostic biopsies as couples go from one center to the other in search of second and third opinions, everybody wants to get a small biopsy to see what is going on. The more biopsies you do, the more scar tissue you create, the less viable testicular tissue you leave behind. And so therefore the chance of having sperm in the final or ultimate sperm retrieval procedure for the assisted reproduction cycle gets decreased a lot. So the message here is don't keep doing unindicated biopsies. If you're planning to do a biopsy in patients with non-obstructive azoospermia, make sure the sperm there has some fate either of getting into the egg or getting frozen with cryopreservation. So I think just moving on, I think with a very high FSH and small testes, I think we know that the diagnosis here is azoospermia due to production defect. I think genetic testing was tested a little bit, and very nice point by Vineet. If there's one test that you want to do, I think AZF is probably the best. So in patients with azoospermia or severe oligospermia, I think doing a karyotype and Y chromosome microdeletion is probably the best. In patients with obstructive azoospermia, thinking about CFTR testing is probably a good idea. So what is AZF-A and AZF-B deletion? Basically, you should not be doing sperm retrieval on them because the chance of finding sperm in them with complete AZF-A and B deletions are close to 0. Whereas with AZF-C, there is still about a 50 to 70% chance of finding sperm within the testis. And so let's move on to surgical therapy, which is what we are all discussing here today. What kind of surgical therapies can you offer these patients who require sperm retrieval? I think a lot of people are very familiar with these approaches of using fine needle aspiration, to use open biopsy, to do multiple open biopsies, and these can be done sometimes under local anesthesia, MAC anesthesia. In your office setting, you probably don't need to think about taking the patient under general anesthesia to an operating room with the presence of an operating microscope. The goal here is to talk about something called microdissection TESE, what the current status is, who should we be thinking about taking to microdissection, and who can probably just benefit from a TESA and a simple open biopsy. And I think the goal here is to understand anytime anyone ever says microTESE, I think we should understand that they are using an operating microscope. A lot of patients are offered microTESE in offices with loops, and I don't think that is microTESE. And I think patients and doctors need to understand that that's what is at least the minimum requirement when somebody says microTESE. What is the principle? The principle is to basically understand and identify the most advanced histology within the testis, to identify small areas of sperm production. And patients and doctors often ask me, which tubule has sperm? I think Vineet alluded to some of the newer technologies that we're working on with imaging to try and see if we can identify which tubule has sperm and which don't. But for now, all that I can tell you is that we're identifying differences in tubule size, differences in tubule architecture to pick out which tubules have and which tubules don't have sperm. This is obviously a nice photomicrograph in the operating room of pretty flat tubules that typically don't have any germ cells inside it, corresponding with Sertoli cell only histology. And this is a nice tubule here in the middle, which could correspond to hypospermatogenesis or spermatogenesis on histology. And so let's watch this 2-minute video. The goal of microdissection is to obviously use an operating microscope. You need an assistant who is capable of irrigating for you. I bivalve the testis in the middle, place 2 clamps on either side of the tunica albuginea. All of these need to be done at a very slow and a gentle pace. This cannot be rushed. You want to be careful to spread the testicular parenchyma very gently with 2 thumbs in the middle. And as you spread, you just want to be careful that you're identifying tubules that are larger compared to most of the tubules here that could be smaller. And that's what you identify, is you want to identify differences in tubules. If all the tubules look exactly like each other under high magnification, then probably that patient did not have a good service with microdissection. So here's a nice example of a pretty large tubule that's clumped in the middle with pretty flat tubules that surround it. And like I said, the biggest thing that you want to do is to be able to identify differences in tubules. And if it's a larger tubule, you want to try and grab the entire tubule and try not to fragment the tubule. And this is something that I do on my own. I process the tubules on my own. I don't depend on the embryologist to process it. I put about 5 to 6 tubules within an Eppendorf tube with an iris scissors, process it with very little fluid. If you put a lot of fluid, it's going to be very hard to find the sperm. And you want to be able to make sure that you put very little fluid, enough that you can pass it with a 24 gauge angiocat like this. And then I usually have a small microscope within the operating room that I can use to identify these rare sperm within the testicular tissue. And it's very rare, and these are typically non-motile. So don't be scared that you did not find any moving sperm, because testicular sperm are usually immature. And so therefore it's okay that they are non-motile, and you have to tell the embryologist that it's okay to use it, even though they are typically used to using only motile sperm for IVF ICSI. And so once you process the tissue, it's important that the lab spends a lot of time searching it. It shouldn't be a 10-minute search or a 15-minute search. It should be at least 1 to 2 hours per testis before they can give up. People always say, microdissection, can it cause a lot of scar tissue? Can it cause loss of viability of the testis tissue? I think that's incorrect. I mean, we showed this very nice study. This is now 15 years ago, where we showed that microdissection actually caused lesser scar tissue compared to conventional multiple open biopsies within the testis. And the same thing with testosterone levels. I think I always counsel patients, if you start off with a low testosterone level after a sperm retrieval procedure, regardless of whether it's open biopsy or microdissection, then your testosterone levels are going to drop. But majority of them will recover. I usually say about a 10 to 20% chance that they will need testosterone therapy, especially if they were symptomatic, especially if they were taking testosterone therapy even before their sperm retrieval procedure, then the chances of needing it are going to be much higher after the sperm retrieval procedure. One of the most important prognostic factors was FSH. When initially, when we were doing these things, we thought that FSH, very high FSH should mean donor sperm. Very high FSH, you have no chance of finding sperm inside the testis. Don't bother with sperm retrieval. But in fact, when we looked at FSH and sperm retrieval outcomes, we actually saw that higher the FSH, the better the chance of finding sperm. And we were a little intrigued and puzzled when we looked at this data closely. We found that men who had normal FSH levels ended up having normal testis sizes and maturation arrest as an underlying histology. And so that was very challenging, because people with maturation arrest will have pretty large tubules, and all of the tubules will look uniform right next to each other. And it's very hard to determine differences between the tubules. Whereas in men with very high FSH levels will have one smaller testes and also tubular differences that we can identify with a microscope. So message here is that FSH level should not be a contraindication for microdissection or sperm retrieval. In fact, men with high FSH and smaller testis size may have better chances of sperm retrieval with microdissection. And I think we touched a little bit about Klinefelter syndrome. This is probably the most common genetic cause of non-obstructive azoospermia. They typically will have very high FSH, very high LH, low testosterone, and majority of them will be azoospermic. And so, nice series here we put together with Dr. Schlegel back at Cornell, where we identified sperm at about 68% of the attempts, 52% pregnancy rate, and you don't need to undergo genetic testing in these embryos because sperm that make it through meiosis, even in patients with Klinefelter syndrome, will most likely be either 23X or 23Y and do not need to undergo embryo testing for genetics. This is one situation where I think medical therapy is useful. I think there was some question about, whether we should be doing medical therapy or not. Often when patients go seek second opinions after a failed microtesy, they always say, oh, that doctor didn't do medical therapy. And so I think even because the risk of medical therapy is so low, it's probably just best to do it in patients who have low testosterone and low LH levels to give them medical therapy. But in Klinefelter syndrome, because of increased aromatization, the first step in medical therapy should be with an anastrozole, 1 milligram once a day. And if the testosterone responds and by increasing, then you just continue the aromatase inhibitor till microdissection. If the testosterone does not respond, then you should think about adding either Clomid or HCG that will predict better chances of sperm retrieval. Of course, in men with Klinefelter syndrome who've never taken testosterone therapy, who have normal testosterone levels to begin with, probably have the highest sperm retrieval rates among all of the subsets of patients with non-obstructive azoospermia. So who is a good candidate for sperm retrieval with non-obstructive azoospermia? I think patients with testicular failure, very small testes, Klinefelter syndrome, Sertoli cell-only histology, post-chemotherapy, and cryptorchidism. I think in patients with maturation arrest, they're probably the most challenging patients because all of the tubules look exactly like each other, and it's very difficult to determine which tubule has sperm and which tubule does not. And same thing with patients who've undergone multiple biopsies at different centers. There's lots of scar tissue both to even get to the testis and within the testis that makes the operation very challenging. So for those of you out there that are going to start microdissection, that are going to start doing these sperm retrieval cases, I would suggest you start with smaller testes, patients with Klinefelter syndrome, Sertoli cell-only histology, as opposed to patients who've had multiple biopsies or have large testes with normal FSH levels with a maturation arrest histology as the underlying problem. So in summary, I think men with non-obstructive azoospermia have a heterogeneous pattern of sperm production within the testis. Just because you have one histology in one area of the testis does not mean it's the same thing in the other regions of the testis. And medical therapy for male infertility, it remains empiric, right? In patients with Klinefelter syndrome, I think it makes a difference. In other subsets, it does not, but you want to weigh the risk and benefit ratio. If the female is young and has time, then trying medical therapy for 3 to 6 months in men with normal or low testosterone levels is probably reasonable. In older females, and you don't have time, probably not a good idea to wait 3 to 6 months for medical therapy to work. And I think microdissection is useful not in everybody with non-obstructive azoospermia. I think in those select patients with small testes, high FSH, Klinefelter syndrome, Sertoli cell-only histology, I think it makes a difference. In patients with maturation arrest, very large testes, where you cannot determine the differences between tubules, microdissection may not be as effective when compared with regular open biopsies. With that, this is my Twitter handle and Instagram. Happy to take questions on these forums, as well as happy to answer questions. And I'd love to thank everybody today for the opportunity.
Vinod?
Vinod? Yeah.
Hello? I'm here. Thank you, Ranjit. Actually, I really appreciate the efforts that Dr. Ranjit is putting, and it's a state-of-the-art technique. And in fact, I was really surprised to see that he is doing that lab work also, because whenever we are doing microthesis, the biggest headache will be the embryologist not responding to our enthusiasm and they say that there is nothing there and we may have to give up after some time. And it's an excellent work, and thank you so much for sharing your experience with us. And now I think there are not much questions coming up because the YouTube is not, the link is not working, and there are no questions posed to us. What I will do as of now is we will take up the Dr. Raman's presentation. He is ready with the slides. So we will go over to Raman and then take the questions at the end, if at all anything. So anybody having questions for Dr. Ranjit and the previous speakers, please send us through Zoom or WhatsApp to the USI's number so that we can take up at the end of Dr. Raman's talk.
I don't know what.
What you, Raman?
Right. So thank you so much, sir, and extremely sorry for the technical glitch that my Mac just restarted without any reason. So we were talking about the overview of a failed varicocelectomy, and we had gone to the fact that failed varicocelectomy is basically a avenue for linguistics, which means it's a new term. You really don't find it on PubMed. But if we look at failure, it basically means a lack of success, a neglect or omission, a state of not functioning. So overall, we'll be considering many new terms here because we're starting with a new term, and to explain new terms, I think we need more new terms. So let's first jump onto two new terms. One is a real failure of varicocelectomy and one is a pseudo failure. So real failure means that the internal spermatic veins, they have, they have been left patent, and this has led to the persistence of the symptoms. Now, for this kind of a situation, if the thing is clinically significant, we do need to repeat the procedure. And what kind of procedure we need to repeat, that we'll discuss in the end of the presentation. This is an objective thing. Everybody can appreciate a real failure because it's objective. And this rarely happens if you have the right awareness, the right skills, if you're using a microsurgical technique and your armamentarium is good. The other term opposite to a real failure is a pseudo failure, where there's just a new radiologist who has over enthusiastically seen your dilated external spermatic veins and cremasteric veins and call them a recurrence of the varicocele. And sometimes whatever you leave over, very small veins, those kind of things are reported as being too dilated. And this is again not as objective as real, but it's a subjective situation. But basically, we can also include infertility, pain, aesthetic concerns, which are persisting as pseudo failure if these internal spermatic veins are absolutely taken care of. Now, we also have to differentiate the failures from complications because, again, ideally a complicated procedure is also a failure, but not a failure in the real sense. So let's look at the clinical scenarios when it comes to failure. So these are some things which we often encounter, like recurrent varicocele with declining semen parameters. There would be no recurrence with declining semen parameters, which we will call a pseudo failure. And then there could be a recurrent varicocele with ongoing pain, which is again a real failure in which compression, ischemia, congestion, increase in temperature, and and the ROS, the reactive oxygen species, contribute. Increase in pain and atrophy are typically the complications. So these are the clinical scenarios that we see in patients who come to us. So now let's come to the first aspect to talk why varicocelectomy fails. So there are two main things that we talked about. Patient anatomy is one, and the surgical technique is the other. So we use usually a laparoscopic inguinal or inguinal microscopic or a subinguinal microscopic approach as surgeons. And of course, many patients also go for embolization, either retrograde or antegrade. And we often make technical compromises when we are performing a varicocele surgery because many of us do it as a freelancing urologist where we don't have, even loops many times. And we are in a very different state where we've not been very used to the theater. We have a new assistant. We've not seen the patient many times. Then there are, sometimes you're just trying to do it under loops because you don't have the investment to make into a microscope, and you're trying to isolate the artery by just pulsations, and you're putting in lignocaine and you're putting papaverine to try and figure out the pulsations. And when it's too tight, when there are so many periarterial adhesions, you often would not want to go there and touch those. So coming on to the anatomical nuances, there are two diagrams that you see here. One is the Behren's classification. So this is important when you're doing a laparoscopic repair. So as you can see, the type 3 configuration is quite common. And when you're making a laparoscopic ligation, you often ligate it below the crossings. And there the spermatic vein has already divided into two. And this remains there and it basically causes the persistence. So this is something which has been most commonly seen in the studies as a reason for persistence of the varicocele after a laparoscopic ligation. The other diagram that we see here is that of the lower side when we approach inguinally or when we approach subinguinally. Here we can see that the external spermatic ones are the ones which often remain outside. But of course, there are studies which say that they don't have a major role to play in the recurrence of symptoms due to varicocele, even if we leave the external spermatic veins and the gubernacular veins. The clinical significance has been somehow told to be not so significant. But again, this is a matter of debate. So basically, our aims mainly remains to ligate the internal spermatic veins properly. So if we look into the various procedures that are already there, and this is a meta-analysis study, so we find that whatever procedure we choose, whether it is embolization, the recurrence rates are quite high, 3 to 11%, as you can see here. Whereas if we do the subinguinal microscopic approach, the recurrence rate or the persistent rates are 0 to 2% as per the analysis. Of course, there are a lot of variations because every surgeon would have a different rate. I have a different rate of recurrences. And but we see that microsurgical approach makes a huge difference. If we just grossly look at what the advantage and disadvantages are, of course, the laparoscopic is easier to do because there are fewer veins, but the recurrence is high because of the collaterals that we talked about. If we look at the inguinal approach, here the veins are less than, I would say, the subinguinal one, but they are more than the laparoscopic one. But basically here we are basically cutting a lot of fascia and muscles. So the pain, the recovery is compromised. So overall the subinguinal becomes a good way to go for managing a patient with varicocele, which is clinically significant. Embolization again is a good technique, but it has some unique risks. And as we can see, the recurrence rate is quite high. So coming to the second part, which is minimizing the failure. How can you minimize failure? This is by choosing a subinguinal microscopic approach. Because as we've seen, this is the best. You have to ligate and cut the veins. It's not just that you can just ligate and let the clips do the job. It has to be ligated and cut.
Raman, just sorry to interrupt, Raman. Your slideshow is not going on. Your slideshow
is not going on. Let me just switch back. Let me just switch back. So give me a second here.
Sir, his slides are seen. He's just discussing on the same slide. He's covering up all the points. We were able to see.
So can you see my slides now as such?
No. It's not,
okay, let me share the screen again. Not a problem. So I hope you can see the slides again now.
Yeah.
You can see the slides, sir?
Yeah, that's true. That's true. We were in the basically one slide was there, which was still.
Okay.
Now it's better. Yeah.
Right. Sir. I hope this is, let us take it forward from here, sir.
Yeah.
So
okay.
basically, so we don't have to spare any vein. Now there could be difference in opinion because we have leaders here with us, but it has been seen when we use a loop and compared to a microscope, there's a lot of difference in the magnification. And specifically this picture I've taken out from one of the excellent papers on varicocele repair, where you can see the periarterial veins have been left if we were just relying on the loop compared to the microscope. So the armamentarium becomes a very important situation. When you come on to the skills, you have to be aware that there are dense periarterial adhesions and you have to make an effort to kind of, separate them from the veins. So this is an instrument that I use. This is the nose scalpel vasectomy forceps. Now this has a relatively better tip to help you separate, but it can also sometimes be dangerous. So I have one which is quite blunt, reasonably blunt enough to give me the edge and give me a finer dissection. Of course, we use a microvascular Doppler to preserve the artery because this is one place where you are really scared to go. And many young people who just into varicocelectomy haven't done a lot of them and don't have the Doppler may want to spare the area where the pulsations are vaguely visible and they're not able to make out if it's the vena comitatus or the artery. We have to also understand that the rationale of surgical treatment is at the ligation of the internal spermatic veins and not the extrafunicular veins, because that's a questionable thing. There is also a doubt on whether we should be delivering the testis, because usually what we are practicing and with good reasonable success is microsurgical subinguinal approach without testicular delivery. This is the typical armamentarium that I use. This is my operating room where we have a comfortable microscope. We are using the testicular microvascular Doppler, and there is a large full HD screen which is connected to a cystoscope. You can say this is a situation where my assistant can also help in ligating and he can see what is going on. Of course, it's not as good as having an cystoscope, but it quite makes for it. At least it's a reasonably priced setup. Now coming on to the later part of my talk, which is managing the failure. So in case the recurrence does happen, how do you manage the failure? So of course, it goes without saying that prevention is better than cure. So before we take the patient up for a varicocele repair, it is the movement there that you need to use to actually inform the patient well about the risk. You have to make sure that the indication of varicocele repair is correct. You have to examine the patient and make sure that there are no other cause or confounding factors, and you're choosing the right patient for your varicocele repair. Sometimes you need to get some labs done to kind of ensure that this is the right patient. And you have to counsel the patient in black and white about every possibility. So all these things, the recurrence, the atrophy, the hydrocele, everything has to be told to the patient, and how you're approaching the patient with the best possible skills and technical armamentarium should also be told to the patient. You have to assess what is bothering the patient. Is it the infertility which is bothering the patient? Is it the pain which is bothering the patient? Is it just a cosmetic concern? Is it a medical exam? You have to counsel the patient. You have to state the facts about that particular case, especially looking at the other possible causes, the absence of the need for treatment. And sometimes you have to certify, if needed, especially for a medical exam, that whatever has been left or is visible is actually not significant enough. You have to expose the scientific evidence in front of the patient to make him understand that he'll know about his subject, and you have to take him back into confidence in case you want to plan something ahead for him. So you have to show the patient the way forward. And sometimes when you feel that the patient has lost trust in you, you may even have to refer him to a reliable colleague who can expose the facts for him. Now, coming back to the place, which is the main topic, how do you really intervene in case there's a real failure which has happened? So here we have to understand why the patient is bothered. If it's a symptom such as infertility, where you see that the varicocele is a direct causation, then you can choose between a subinguinal microscopic ligation or embolization. Now, this again depends on what was the previous surgery that the patient underwent. So going back to the index case, there was an open inguinal approach which was used. So here we could choose both subinguinal microscopic ligation and embolization. Now, when you compare these two, we still don't have enough studies to say which one is better, but there are more studies on subinguinal microscopic ligation for managing a recurrence of varicocele compared to an embolization. Both have good results, but we still need randomized controlled trials to compare which one is better. But since we are surgeons, we are more comfortable with what we do with our own hands. I think the right way to guide the patient would be to go for a subinguinal microscopic ligation in this index patient. If he has already underwent an subinguinal microscopic ligation, there are concerns about dense periarterial adhesions being there, in which case you may as well choose an embolization if the patient's finances and if the patient agrees. If the reason for the concern is a pain, then basically we need to go for something like a spermatic cord block, where you can use bupivacaine with steroids and assess the response. If there's a good response to the block, then it means that we can go ahead with something else like a denervation. Also, we have to look into the fact how much of it is because of the residual varicocele. For example, in this case, there was just a grade 2 varicocele, unlikely to be causing the symptoms. So we have to think about unrecognized pathologies, central sensitization, coexisting pudendal pathways, and even sometimes malingering by the patient. Many times you will just be able to manage these patients with medical management, but for patients who, for whom we are not satisfied that varicocele is the right cause causing the symptoms, we have to resort to something like an ART so that they have a good take-home baby rate. And it has been seen as per studies that even with patients who have had a varicocelectomy, the results of an IVF or a ART intervention have been similar to those of normal couples.
Dr. Raman, can you just...
Yeah, so this is the take-home
Okay.
message. So patient counseling has a major role to play here, and pre-surgical evaluation is very, very important. It's more important than we think. Complications and possibilities have to be explained to the patient without fear of losing the patient. We have to be very open about it. We have to use the best available technology, which you will not regret if you invest in. So the subinguinal microscopic vein varicose ligation with intraoperative testicular artery isolation with microvascular Doppler is what I trust and believe in. You have to ensure that the patient trusts you and understands you, and you have to state the facts to infuse confidence. With this, I thank everybody, and again, sorry for the glitch.
Thank you, Raman. Even though there was a little bit of technical glitch, we could manage it, and it is a very important topic, and everybody must have get rid of many of their doubts in their mind. There are a few questions which have come up through the chat box, which for most of them, Dr. Ranjit has replied in person to that. I think we will move on to the erectile dysfunction part because we are actually 7 minutes late. Still, if we are having time, we will ask Dr. Ranjit to answer those questions because some of them are specifically sent for Dr. Ranjit. So now I invite Dr. Garrafa for his talk on concealed penis, a cause of worry. Because this is a very, very problematic case which many of us may ignore, especially when the general practitioner may also ignore. Sometimes when it comes to urologist also, we may say that this is fine. And finally, the patient may go even for psychiatric problems. And Garrafa has done a lot of work and research in the management of concealed penis. And over to you, Garrafa, for your talk on that.
Okay, are we ready?
Yeah.
Can you hear me?
Yeah, we can hear you. And
okay,
I think
I can see my slides, but all your pictures of all of you have disappeared from my screen. Is it okay? Can you still hear me?
It's fine. It's fine. But you have to share your screen.
Okay.
Is it fine? Otherwise, okay. No, only the Zoom picture has come.
It was working, and no, when we tried earlier.
Yeah. Otherwise, we'll ask Mr. Navneet to protect it from the office. Navneet?
Can you see? You are sharing your screen. I'm sharing now. Can you see me?
Yeah, but the slides are not come. Navneet? Can you share the screen? Yeah, yes, can you protect it from your side?
Yes, sir.
Dr. Garrafa, you can start the presentation, and whenever you want to change the slide, you can just tell that to change the slide. They will do it from the office.
Okay, it was not the way I wanted to do because I would have rather changed the slide myself because there are many slides and it's quite quick. Can you give me just 1 minute to try again to try to share?
Okay, fine.
Share screen. Share. Can you actually see now?
Yeah, it's fine.
Oh, perfect. Okay, first of all, I wanted to thank the faculty of USI for being kind enough to invite me. It's always a great honor. It's obviously a relationship that started from the USICON meeting in 2017, and again, we have met again last year in Bangalore, and now again, I have an opportunity of seeing my friends from India. First, we will discuss about concealed penis and what can we do about it. First of all, you need to understand exactly what the anatomy of the penis is, and obviously how much is visible of the penis depends not only on the exact length of the corpora cavernosa, but also on the extent of the prepubic adiposity and the characteristic of the penile skin, as you can see from this slide. there is no agreement on what should be the average length of the penis, both in flaccidity and in the erect state. But as you can see from this slide, the average stretched erect length varies between 12.5 and 15 or 16 centimeters. Most series consider the stretch length, as this may prove to be an adequate representation of erect length. And as you can confirm from this slide. Obviously, the size of the penis depends on the thickness of the prepubic adiposity, and the size of the prepubic adiposity tends to increase with age as much as the metabolism slows down and the levels of testosterone reduce. Certainly, there are conditions that cause penile shortening. So any form of tunical or cavernosal scarring, such as Peyronie's disease or cavernosal fibrosis secondary to explantation of penile prosthesis, or long-term erectile dysfunction, or previous low-flow priapism, as well as direct trauma, such as urethroplasty or pelvic trauma, or patients who were born with a reduced size penis, a micropenis, which is by definition a penis which is less than 7.5 centimeter long. Certainly, penile size is associated with men's self-esteem, and therefore addressing penile size issues is extremely important. Certainly, this is not an easy topic, and therefore this needs to be addressed by a multidisciplinary team very often, in which there is a urologist with interest in reconstruction and andrology, plus often a psychologist, because it's very important that patient expectations with any form of treatment needs to be reasonable. Sorry. For some reason. Okay. So as you can see from this slide, the vast majority of men fall in the normal size penis, as by definition, a small penis or a micropenis is defined as something that is more than 2 standard deviation below the mean, which in clinical term would be 7.5 centimeter. So which are the conditions that benefit from surgery? Certainly, micropenis would benefit from surgery, but in those patients, most often you wouldn't go and work with the actual corpora cavernosa of the penis. What you would do is you would offer a complete phallic reconstruction, and there are various techniques according to what are the patient expectations and his anatomy and the extent of abdominal scarring, especially for patients with previous epispedia and bladder exstrophy surgery. Surgery, patients with buried penis would benefit because the presence of a buried penis will cause pooling of urine, recurrent infections, and skin changes that potentially can lead in the long term to developing penile cancer, as well as more acute urinary tract infections. Often the buried penis is linked to lichen sclerosus, also known as BXO, due to the constant maceration of the skin, or patients who have lost excessive amount of skin due to circumcision or trauma. Okay, this is a patient who certainly would benefit from surgery. This is a buried or concealed penis. As we have discussed, this can be a combination of 2 things: excessive prepubic adiposity and or inadequate penile skin due to conditions like lichen sclerosus, or traumatic, for example, excessive circumcision, or for some reason. Okay, so this is the example. In these patients, it's very important to assess the quality of the skin of the penis, because very often, due to the constant maceration and chronic infection, there will be changes which will render the skin of the penis not usable. And what you have to do is to do an extensive apronectomy in which you will dissect all the excessive skin and the prepubic adiposity in order to restore the adequate penile anatomy. And very often you will need also to excise all the affected skin. In this patient, he has been reasonably lucky. Most of his penile skin was still adequate, and therefore he only required a circumcision. But for example, in this patient, the situation is different. He had a buried penis, and due to the presence of lichen sclerosus, he had multiple circumcision, which basically left him without any penile skin. So what we will need to do in this case is not only to extract the penis, but also we will need to reconstruct the penile skin. And as you can see, the common rule is for shaft skin, you need to use a thick split thickness skin graft because they will heal with less contracture, and therefore they will allow the penis in the future to expand in girth and length when a patient has an erection. While for the glands, you tend to use a thinner skin graft because it will better accommodate on the surface of the glands. And this is what the outcome in the long term is. It's very important to restore adequate erection postoperatively, as early erection will stretch the graft and prevent the graft from contracting, giving a poor functional outcome. This is another example of patients who would require reconstruction due to concealed penis. He had an excessive circumcision. The prepubic adiposity is actually not important. And again, in this case, what he will need grafting with a full thickness skin graft or a thick split thickness skin graft, as you can see from this slide. Other patients may seem to have a concealed penis, but in reality, they had an excessive circumcision with a penoscrotal web that has been transposed up to the corona. And what here will need to be done is an excision of the penoscrotal web, and this will give an adequate cosmetic result. Another condition, which is way more rare, is the scrotal transposition, in which the penis is located more distal than the actual root of the scrotum, and here with bilateral VY plasty and partial scrotal excision, you would be able to get adequate cosmetic and functional result. Now let's talk about penile lengthening. So we have to distinguish here between lengthening in the flaccid state or in the erect state. With regards to the flaccid state, there are some surgical and non-surgical technique. The non-surgical technique involve all the various forms of penile stretching. And there have been various companies and various urologists who have devised devices to try to produce penile stretching. And as you can see from this slide. But there is no evidence that using the stretching device would improve penile size unless the patient has fibrosis of the corpora, and in that case, stretching may help to restore part of the length lost, or postoperatively after penile surgery, but rather than to gain any length, in this case is to prevent length loss due to scarring and contracture. The division of the suspensory ligament, as you can see from this slide, which often is accompanied by a vulvoplasty to gain a bit of extra skin, especially in patients who had a previous circumcision, will allow to gain length in the flaccid state. When you divide the ligament, you have to appreciate that the ligament would reattach spontaneously. So in order to prevent that from happening, you will need to put a silicone buffer or any buffer between the pubic bone and the penile shaft to prevent this from reattaching. And as you can see from this slide, the vulvoplasty also will help to gain some extra length in the flaccid state. And this is what's the final result in the long term. Usually the scar is not very obvious, especially if patients don't shave the hair in the pubic area. As you can see from this slide, this is a slide that I always show patients who are interested in penile augmentation. Penile size will increase in the flaccid state, but there will be only a very minimal or absent increase in stretch penile length or in erect length. And this is something that patients always need to be aware of. Although in the flaccid state, the increase can be as up to 4 centimeters. So if patients are happy to increase their size in the flaccid state, then division of suspensory ligament may be beneficial. But in patients who want to increase the erect length, then obviously that it's useless. There are various authors that have tried to describe techniques to actually increase the size in the erect state, such as the technique of Perovich, which involved the use of a cartilage that is applied on the tip of the corpora cavernosa. But to be honest, this technique involves excessive dissection. There is a significant risk of vascular injuries to the glans penis because both the urethra and the neurovascular bundle are elevated. And also, you have to appreciate that the limiting step is the stretching of the neurovascular bundle that by definition cannot expand. So you won't be able to gain much length. And this is a picture that's a courtesy of Sava Perovic from the School of Belgrade, who actually published in the early 2000s this series, where he actually was able to achieve a length gain of 2 to 4 centimeters. And again, the limiting step was the stretch of the neurovascular bundle. When you have to implant a penile prosthesis, you have way more option to increase the actual length of the penis. And the reason is because you would be able to make incision on the tunica albuginea and potentially graft without having any impact on the quality of the erection. Because by definition, whenever you do a tunical incision and you put a patch, the quality of the erection will deteriorate. If the patient is going to undergo penile prosthesis implantation anyway, then this will not be a problem. And there have been various techniques, from the initial technique described by Ustoni and Montorsi to the more recent technique, which are the sliding technique, and then the multiple incision technique, and subsequently the vest technique. As you can see, the initial description of the sliding technique involved only 28 patients with an average length gain of 3 centimeters. You have to appreciate from this slide one important factor. Infection rate is 7%. And we do know how many authors like to reduce their infection rate by excluding cases who had complications. Infection rate in a virgin penile implant should be 1%. So patients who are undergoing this kind of technique need to be warned that the risk of infection is close to 10 times higher than in the normal population. Plus, there are other significant risks, which are necrosis of the glans penis due to vascular complication, because both the urethra and the neurovascular bundle are elevated. And therefore, patients who have already a compromised blood supply, for example, patient who had previous radiotherapy, for example, post-prostate cancer, or who had a urethral surgery, then they shouldn't be offered this technique at all, because they will be at much higher chance of developing a complication. Then this technique obviously have been modified by Egidio, for example, with the multiple incision sliding technique, in which in his series also he was able to gain around 3 centimeters in length. But again, the risks are the same. You will end up mobilizing extensively the neurovascular bundle and the urethra with the potential risk of compromising the blood supply to the glans penis. Duration of surgery will be increased, and therefore infection rate will be higher. Now let's talk about girth augmentation. Girth augmentation, luckily, contrarily to division of suspensory ligament, will increase both flaccid and erect girth. And obviously, depending on the type of technique you use, the results may be temporary or permanent. For example, the way to increase girth is either with grafts, which is what I used to use in the past, but I've now abandoned it because of the duration of surgery, because you will need to add the morbidity of a second incision to harvest the graft, usually dermis or dermal fat grafts. And also the fact that the graft will or may contract, causing loss of length. Or you can use fillers or fat injections. The advantages of fat and fillers is that they are much quicker techniques, but obviously you have to appreciate with the use of fillers, the filler will desorb physiologically over a period of time, which may vary between 6 months and a couple of years, depending on the type of filler. And therefore, those patients will need to be warned that they will need to repeat the procedure on regular intervals in order to maintain the cosmetic results. This is a patient, for example, who had both length augmentation with division of suspensory ligament and girth augmentation with the injection of autologous fat. The fat usually, or the adipose tissue, is harvested from either the abdomen or the inner thighs during the same procedure, is processed, and then is injected around the shaft. Patient needs to be warned that around 30% to 40% of the adipose tissue will be reabsorbed, and therefore they will experience a reduction in the girth over the first month. But for example, this is a gentleman who had a previous penile enlargement with division of suspensory ligament and autologous fat injections. And obviously he was not happy with the girth because he had lost some girth. And here it was a picture of him after a top-up. And so an alternative is the use of grafts. You can use allografts, for example, bovine pericardium or stratasis. This is, for example, is pelvical. But again, the use of pelvical will cause intense scarring and may cause penile shortening. Plus, the patient may feel the edges of the graft, which may give a poor cosmetic result. So it's something that I would not recommend anymore. So this is my presentation on concealed penis and what you can do both to increase flaccid and erect length and the girth. And with this, I thank you very much, and I hope I've been inside my time.
Thank you, Dr. Garappa. Can you stop sharing the screen? Actually, Dr. Garappa has told us what are the permutations and combinations that can be done to increase the length of the penis and the girth of the penis. Mostly in a normal penis, otherwise normal penis. But when it comes to the case of a Peyronie's disease, our challenges are different. I think Dr. Renchit will be discussing in detail about how he is going to choose a technique for the treatment of Peyronie's disease when a surgery is indicated. Over to Dr. Renchit.
Thank you so much again. You know, pre-corona, we traveled around the world to give talks and people and share and exchange ideas that way. Certainly, this is a very new way of exchanging and sharing ideas. I think it comes with a lot of benefits. We don't have to travel much. We're not jet lagged. We're not tired. But we certainly miss out on visiting and seeing things. This is a nice picture with Marlon and Rupin in Ranthambore, where we went to see tigers. You know, we used the opportunity to teach andrology, but at the same time, we also saw things. Hopefully, Corona will end. Hopefully, we all get back to some sort of normalcy where we are able to do both webinars. I think we've learned in a way that we can actually teach and learn effectively through online modalities. But certainly, I think we should also get back to doing where we actually, as humans, see each other and actually interact more than just doing this online thing. So praying for things to change, and hopefully we'll see and into this soon. So the goal for today is to talk about Peyronie's disease and pathophysiology and why it happens and what we can do with surgical treatments. So whenever patients ask me, they're like, Doc, why did I get a curved penis? I think that you explained two things. One, I think they need to have a genetic predisposition to forming curves. So when two people get hurt, some people scar differently than the others. And the same thing happens with the penis every time when you have sex. I think there's some micro trauma that happens and creates scar tissue excessively in some people than in the others. And I think that's what it does. If you're celibate and never have sex, I don't think you'll develop Peyronie's disease. And again, if you don't have the genetic predisposition to forming scar and the scar leading to curve, I don't think you'll develop Peyronie's disease. So it has to have a combination of both sex as well as the genetic predisposition to scar tissue. So treatment of Peyronie's disease can be broadly classified into medical therapy and surgical therapy. Up until a few years ago, we didn't have too many medical treatments, but now we actually do in terms of intracavernosal injections. Verapamil and interferon have been used worldwide. Collagenase or Xiaflex is the most recent FDA-approved medication, probably the only FDA-approved medicine that we have with randomized control trials are showing that it's effective. In terms of the oral and topical agents, all of this have very weak data. Patients who take it, I ask them to continue taking it, not to stop it, but you also have to tell them that it's most likely not going to work in a way that they want it to. So just let me briefly touch upon collagenase and Xiaflex before we move on to surgical therapies. It is a very arduous and difficult protocol. So it's a total of 8 injections that are given over a period of 6 months. It's 2 injections every 2 to 7 days apart, and no sex for about 4 weeks after these injections are given. And so it's pretty arduous. It has side effects, and success rate at best is 50%. I'm fairly certain with other intracavernosal, intraplaque injection therapies, success rates are also pretty similar. So a lot of work, but to basically tell them that there is a 35% chance improvement compared to placebo, in which this was saline injection inside the penis was a 17%, I think is a lot, but we have something. So patients are afraid of surgery. They don't want to undergo surgery because it's their penis. And so for those patients, at least we have some option that is with clinical trials shown to be 50% successful in some patients. So some of the examples that you see, basically it's an injection that's given it directly at the point of maximal curvature, not throughout the entire scar, and you see some 33% change from the baseline. So today the goal is to really talk about surgical treatments, and I'll discuss about plication. When do I choose plication? When do I choose grafting? And when do I choose penile prosthesis? All 3 are effective and good treatment options for patients with Peyronie's disease. So in terms of surgical treatment, I mean, you have to understand plication is basically using sutures on the opposite side of the curve to try and shorten the curve on the other side without touching the plaque. Incision or partial excision and grafting is basically going to the plaque, basically either incising the plaque or trying to remove a part of the plaque to put a graft on there to cover the gap. And finally, insertion of penile prosthesis with straightening maneuvers are also a good treatment option. So these are basically the 3 surgical options that are available for patients with Peyronie's disease. So this is probably the best algorithm that I'm going to show today, if the curve impairs intercourse or not. And that's the first question you want to ask patients. Some patients are okay with the curve. They're so scared of the curve, they come and talk to you about the curve. But if you tell them that does it actually affect intercourse and they say no, just leave them alone. Reassure them, provide them traction devices so they can do something with their penis, and leave them alone. If it does impair intercourse, then you want to ask the most important question: is your erectile function intact or not? Sometimes you see severely diabetic men with hemoglobin A1Cs of 10, 11, 12 with Peyronie's disease, and they say the erections are good, but then when you truly ask them in more detail, then they tell you the erections are bad. And the erections are bad, or when you do a Doppler ultrasound and you see elevated EDVs or low PSVs, then you have to think about taking them straight to a penile prosthesis. And I can't stress this any further. If you take a patient with impaired erectile function to either of these procedures with grafting or plication, then their outcomes will be poor, because now they will complain of erectile dysfunction now after the surgery, and somehow the plication and the grafting, even though it cannot directly affect erectile function, will be your problem now that you caused the ED after the surgery. And so 2 important questions to ask: does the curve affect the intercourse? If the answer is no, just offer them reassurance and or traction. And what is their erectile function? And if the erectile function is poor, guide them towards penile prosthesis with modeling and other adjunct procedures. And if the erectile function is good, then think about discussing either medical therapy with collagenase interferon or verapamil, or surgical treatment options with plication and grafting. And so preoperative considerations for patients with Peyronie's disease, that's what you want to do. You want to ask about erectile function. If you cannot get a good history, think about doing a Doppler. Do they have an hourglass deformity with an intracavernosal injection in the office? What is the degree of curvature? Is it 30 degrees? Is it 90 degrees? Is it 10 degrees? All of that makes a difference, because patients will tell you it's a curve, but then when you truly assess the curve, 10 degrees, some patients could be bothered by it a lot. 70 degrees, some patients won't. And you want to make sure that you objectively assess and document these things in the patient's chart before you think about surgery for Peyronie's disease. Plication technique, there are many ways to do plication technique. Some patients use a circumcising, some doctors use circumcising incision, and some don't. And make sure you're truly, this is Peyronie's disease and not congenital curves. I use the tunical plication technique. It's just simpler, it's faster, it decreases the chance of affecting erectile function, decreases the chance of using the neurovascular bundle, and so much easier to do it that way. And the biggest disadvantage is, and you have to tell patients that they are going to lose a couple of centimeters, not an inch, but a couple of centimeters. And so therefore the chance of risk of penile shortening should be there with plication. You document it, but it's certainly not much in patients who have an average length. And so these are some of the couple of ways in which you can do it. Either the Nesbit procedure or the modified Nesbit with the Yakia technique, in which you can incise the plaque. And so, or if you're not comfortable incising the tunica, sorry, not the plaque, then you can just sew with preferably either Dacron or Ethibond sutures, which are much longer lasting than absorbable sutures. When it comes to grafting, I think excision has sort of fallen out of favor, but incision is still in fashion, wherein you can actually incise the plaque and place a graft. And grafts can vary anywhere from tutoplast to now the more common, the German technique, using just the patch that is placed over it without actual sewing of the graft onto the tunica. Certainly a very good approach in patients who have extremely large curvatures, like 90 degrees or higher, and patients who do not who have good erectile function. Some of the advantages of incision and grafting are basically return of length. Like patients have lost length and you can give them the length back. And certainly you can correct just about any deformity, hourglass deformity, greater than 90-degree deformity. However, there's lots of disadvantages when it comes to this. You have to talk to them about risk of developing ED, risk of developing numbness, risk of graft contracture, and 20 to 25% of patients who undergo this technique end up needing some sort of adjunct procedures. And so you want to talk to them about the risks and, more importantly, document the risks. This is not for the lighthearted andrologist. This is not something you want to be attempting first. Plication is okay to do. Grafting, not the same skill level, and you want to make sure that you're going in fully prepared. So these are some examples of operative pictures of identifying the plaque here and excising the plaque or incising the plaque and grafting. Same way, it's a nice approach here to basically remove the tunical plaque and place a graft here with bowing pericardium. Sometimes you can just excise the plaque partially and place a graft like this, but certainly the patient selection in these cases are very important. You want to make sure counseling has been done very well. Penile prosthesis for Peyronie's disease, I love the approach. This most patients with Peyronie's disease, I feel, have some sort of underlying erectile dysfunction. Peyronie's disease is a disease of scarring. And so it's not just the small plaque where there is scar, but there is calcification and scarring throughout the penis. So most patients with Peyronie's disease long-term will develop some sort of erectile dysfunction. And so you do want to think about using adjunct procedures with modeling, but as long as I'm able to get the penile implant in without any issues, I'm pretty happy with treating patients with a penile implant for Peyronie's disease. Certainly, if you're not happy with the end result, you can do modeling. Make sure you clamp off the tubing so the pressure doesn't get transmitted back to the pump. And so therefore, manual modeling is certainly a good idea in patients who you have placed the implant in already. So if you look at the AUA guidelines on Peyronie's disease, it basically goes over this. You should think about using plication and plaque incision and excision grafting in patients with good erectile function. And certainly in patients with erectile dysfunction, you should think about offering a penile prosthesis with or without modeling or plication as adjunct procedures along with the penile implant. Nice algorithm again in the AUA guideline. Certainly follow this closely, document very well. Patients with Peyronie's disease have the option to be unhappy because they came in for you for a curve, but they didn't think about their underlying erectile function. It is your responsibility to figure out what the erectile function is and guide them to the proper surgery, because they can end up unhappy if you do the wrong operation. And so in conclusion, I think the prevalence is very high. We're seeing a lot more of this. Intralesional injections are useful. You can offer them, but don't offer them too much success beyond 40 to 50%. We do finally have one collagenase medication that's FDA approved. In patients with good erectile function, certainly talk to them about plication and grafting as good approaches. In patients with significant erectile dysfunction, do not talk to them about the other surgical options. Penile implant should be on the forefront. With that, thank you so much, everybody, for the opportunity. Obviously, there's so many youngsters in the audience. You guys don't like to email anymore, but you can follow me on Instagram and direct message me on Instagram or on Twitter. But for all those who are still emailing people and WhatsApping, this is a very good way to communicate with me. But thanks so much, Vinod and USI, for this wonderful opportunity. And obviously, this is a great webinar to stress the importance of andrology. Thank you.
Thank you, Dr. Ranjit, for that excellent talk. You have really inspired many of the young colleagues who have joined us to take up this specialty in a serious way. Now comes a question of our routine patient who is complaining of erectile dysfunction. They are initially evaluated and given PDE5 inhibitors. The question is, most of them will have already taken PDE5 inhibitors, and they will come and ask, I have finished up all the PDE5 inhibitors. What to do next? I invite Dr. Shivam to discuss about the role of intracavernosal injections, how he is practicing it, what is the logistical issues, and how he can practice it in an Indian setting. Over to you, Dr. Shivam.
Thank you, Vinod. So this is our index case, which is not responding to PDE5 inhibitors now. So my journey of andrology started with this workshop, which was in January 1996, taken by Dr. Rupin Shah. And this is the 25th year, the Silver Jubilee year of my andrology practice, and I dedicate this talk to Dr. Rupin. So before going into the second line of therapy in this patient, it is very important to know what are the reasons that PDE5 inhibitors are not responding. So one could be an unrecognized hypogonadism, which would be can be helped by androgen replacement, inadequate patient education or incorrect drug uses, which could be corrected, or by education, and psychosocial issues, which can be corrected by counseling. There are cases where you could have a tachyphylaxis where there is increased PDE5 expression in the corporal tissue with chronic therapy. And again, there could be a progression of the disease or associated comorbidities like diabetes or metabolic syndrome, which can lead to non-response. So coming to this, when I was with Tom Lu, he used to ask the nurse to give either 1P, 2P, or 3Ps. So the popular drugs for intracavernosal injections are the 3Ps, papaverine, phentolamine, and prostaglandin E1, either used alone or in combination. There are other drugs which have been experimentally used, which are VIP, serotine, atropine, sodium nitroprusside, etc. We all know that intracavernosal injection have been used for diagnostic purpose as an office procedure. It has also been used along with color Doppler and for other imaging studies like angiography, for cavernosography. There has been a recent surge in interest of penile rehabilitation protocol with intracavernosal injection after radical prostatectomy. But home self-injection program as a treatment for erectile dysfunction, though it has great efficacy, but it has been underutilized. We know the injection has to be given on the lateral aspect of the penile shaft, sparing the dorsal neurovascular bundle, and on the ventral side, the urethra. Usually you get a good erection, rigid, with 5 to 10 minutes. Sometimes there is an anxiety with the needle or the needle phobia. And here we can train the wife or the partner to give the penile injection. We have also auto injectors which can overcome this phobia. Recently, technology has given some needleless injections also, which can come into the market anytime. The erection is not maintained. And because of the veno-occlusive dysfunction, we need to put a penile ring at the base of the penis to maintain the erection. We have developed this ring over the years, and which is very simple and easy to use in comparison to the vacuum device rings. So when we are talking about the home self-injection, it's not only effective in patients who are non-responders, but also in patients where the drug is contraindicated, where it is not tolerated, or even in cases where a faster onset of erection is desired, like in an unplanned sex, and even in cases where we need to combine both PDE5 inhibitors and intracorporeal injections for better efficacy. I have been using the Bimix, Pipervarine, and Chlorpromazine for last 25 years with very good results. The initial dose is as little as 0.05 ml, and it is titrated to 1 ml for optimizing the erection. Occasionally, I've been using the prostaglandin E1 and the Trimix. The first injection is usually a injection, and then later the dose is titrated to produce an erection which should last at least for 15 minutes and preferably within 1 hour. The patient is asked to self-stimulate after the injection, and he is trained adequately in the clinic before giving or dispensing them the pre-filled syringes. Some of the other indications are like a young unmarried man who has a performance anxiety and needs a reassurance. So 1 or 2 shots of this injection will help to reassure this patient and build up the confidence. Unconsummated marriage is again one of the important areas where this injection is probably the first line therapy, and few weeks or few months of treatment will help the couple to consummate the marriage. In patients with psychogenic impotence, also a few weeks or few months of treatment can help to regain the spontaneous erections. Long-term therapy is usually required in patients who have neurogenic impotence or vasculogenic or refractory case of psychogenic impotence. The drug is contraindicated in patients who have lower IQ, unreliable, who have physical disability, who have buried penis, conditions like bleeding disorders, or patients on anticoagulants, uncontrolled diabetes. It is contraindicated. Coming to the complications during injection, the most important is the pain, which could be due to the others like urethral bleed or hematoma formation or a bruise, or sometimes even a needle breakage in the cavernosal tissue can happen. After injection, the most important is the prolonged erection or the priapism. And in the long-term therapy, it could be fibrosis and sometimes a plaque formation, which can result in penile curvature similar to Peyronie's. So pain occurs mostly with alprostadil or the prostaglandin E1, and it can be minimized by combining it with sodium bicarbonate or procaine. Fibrosis often happens with Pipervarine and Bimix or Trimix, and this could be minimized by changing the site of injection, changing the side, using always a fine 30-gauge insulin syringe needle. Priapism or the prolonged erection is the most dreaded complication, and it occurs more commonly with Pipervarine and Bimix, Trimix, least with prostaglandin E1. It could be minimized by always dispensing the drug, always using the lowest effective dose, warning the patient never to exceed the dose, warning about the dangers of priapism, and always providing him with an alternate contact number in case of medical emergency. Some patients who are motivated, young, educated, they can be provided with prefilled syringes of vasoconstrictor drugs to inject them when there is an emergency. This is my protocol of how I follow in a case of prolonged erection. I never allow the erection to go beyond 1 hour in office. And after 1 hour, I ask the patient to run in a nearby garden for 10 to 15 minutes. And this usually helps in detumescing 1/3 of the patients. The next thing is about the oral terbutaline, which I give 5 milligrams every 15 minutes. And this helps again in 1/3 of the patients. If it's not responding, then intracorporeal injection of vasoconstrictor drugs may help. If the patient comes with priapism, then we need to do aspiration irrigation or a slow
No.
Perhaps loss of connection, sir.
Okay. I think Dr. Shivam has lost his connectivity.
glands into the corpora, and that can, pardon? That can help in improving the patient. And most of these middle and proximal shunts are usually not used nowadays. If the patient is coming after 72 hours, then we have to do a penile implant. This was a study that we did with oral terbutaline and was published in 2004 in International Journal of Impotence and Research and has been cited in Campbell's Urology too. Dropout rate is quite high with home self-injection program, which could be due to poor erectile response, inconvenience, switching to other therapy or adverse events happening, or even return of the spontaneous erections. So this acceptance can be increased by properly training the patient mix and trimix, which is less painful and easier to inject by giving them preferred syringes. And if the patient is too scared of the injection, then we give them auto injectors or train their wives or partners to give the injection. We did a study of this bimix of papaverine and chlorpromazine, which was compared with papaverine alone and was published in 2015. There, the results showed that it is equal in efficacy as the conventional bimix, that is papaverine phentolamine, and is much better in efficacy than papaverine alone. This is one of the newer invention where this implant of a drug delivery system which is implanted, and the reservoir which is put in the scrotum when squeezed delivers sodium nitrate, which helps in erection. So to conclude, is an important tool in treating and diagnosing erectile dysfunction with a very high patient satisfaction and efficacy rates, but underutilized, and the dropout rate remains quite high, and the patient should be educated on the benefits and limitations of this therapy. Thank you.
Thank you, Dr. Shivam, for that presentation. And we learned a lot about the role of, in fact, having a lot of patients coming up with erectile dysfunction, especially with the advent of diabetes, prolonged life expectancy, and probably because many of them are surviving even with the prostate cancer because they are doing radical prostatectomy in a big number. So the number of erectile dysfunction patients are going to be on the rise. And we really want Navneet, you are not able to fix it?
Sir, it's stuck at his end, sir. Now I will be, I'll get it.
Okay. Pramod?
Yes, sir.
Yeah, okay.
Yeah, so the slides are the same, sir?
Yeah, it's seen, and then
Okay.
you can proceed.
Yeah, okay. So this is the clear instructions that I received from Dr. Vinod. So what we will try to discuss here is that, of course, we will not be able to discuss step-by-step procedure of the penal prosthesis surgery. We will give you tips and tricks, and also we will discuss about what precautions we need to take and how to treat the common complications that we encounter during the penal prosthesis surgery. Yeah. So I will just present few slides initially to just give a brief introduction. Worldwide penal implantation rates have increased. As you see here, the AMS and Coloplast are the leading manufacturers of the penal prosthesis procedures, and AMS leading on the top. And if you see the United States, the 80% of the penal prosthesis work is done in the United States as compared to the other countries. And what does the recommendations say is that things are changing. The penile prosthesis need not always be the last option. In fact, all the options of the management of erectile dysfunction should be explained to the patient in the first outpatient visit. This is what even AUA says, but the EAU still keeps penile prosthesis as the third line therapy. So let's try to discuss things related to Indian scenario. So what do we have currently in India? The processes which have appropriate regulatory approvals are, the first is the SHA, this is the malleable one. And in the center, you see the AMS Ambicord, that is a 2-piece implant. And on the right, you see the AMS 700, which is the 3-piece inflatable implant. Since some of the residents will be watching here, so I just put up this slide. As you see here, the 3-piece implant, the pump will be in the scrotum, and the cylinders will be in the corpora cavernosa, and the reservoir in the lower abdomen or in the pelvis. So, yeah, and it's also important that since this discussion should also cover about how to start a penal prosthesis program, it's essential that we use devices which have gone through the regulatory process. Dr. Hota sir, can you please comment on this about using the regulatory approved penal prosthesis here?
Good evening, everyone. Am I audible?
Yes, sir.
Need to be a little
Good
louder.
evening, everyone. First of all, yeah.
Hota, come closer to your, yeah.
First of all, I'm very thankful to USI, all the functionaries and the participants for giving me this opportunity. I'm equally thankful to Dr. Rupin Saab, who has inspired me for last 25 years. He came to our place 25 years back in 96. So I'm really thankful. And as the question is concerned, Dr. Pramod, as you know, only 3 types of penile prosthesis are available with the approval of the DCGI, Drug Controller General of India. And in our country, the statistics that you have shown is 80% of penile prosthesis happens in the United States, and our country comes toward the very last. That shows that we are not using too much of approval of the Government of India, DCGI. The only 3 are approved. We should use the approved penile prosthesis. We should not use which are not approved, even though they are available through importing by different agencies. So as of now, the Coloplast is not approved, and we should be facing some legal implication if we use a non-approved one. That will be my recommendation.
Yes, thank you, sir. So yeah, the other malleable implant, I think some of you must have used the AMX Spectra malleable implant in the past, which has been withheld 2 years back. So the new Tectra malleable implant got released last year during the AUA. May come to India in December this year. Okay, and also the next most important thing is that all of us should use a detailed consent forms for the penile prosthesis surgeries. And you can access these from the SMSNA website, that is the Sexual Medicine Society of North America, or from the other article from Kovach et al. And also it's important that one should be aware of the cursed patient, which Trost et al. Have beautifully termed this in the Journal of Sexual Medicine 2013. where we need to spend extra time or be cautious of the patients who have compulsive obsessive disorders, who have unrealistic expectations of wanting for a big, larger, harder penises, and those who have psychiatric issues. So it's better that you take a psychosexual counselor's help before you plan any penile processes on them. And it's also important that you have a checklist in your hospital so that the things are arranged before you enter the OT, and the assistants and everybody are aware of what things are required, so that you can avoid too much of in and out movement in the operation theater, which can also affect the infection rates. And just to give you a brief idea of how the penile process is done, I prefer going a penoscrotal approach, and you dissect the corpora, and then you do a corporotomy, and then you give a corporal wash, antibiotic wash, and then you see the sharp penile process is placed here. And this is how the post-operative picture it is. Yeah. So coming to sir, Dr. Shivam sir,
Yes.
regarding approach, different approaches which can be practiced for a penile prosthesis surgery. So could you please elaborate on what are the different options available for the prosthesis surgery?
Thank you. The approach would depend upon the specific anatomy of the penis. It would depend upon the type of implant to be implanted, and it would depend upon if there is any history of pelvic surgery in the past, and definitely on the surgeon's preference and his experience. I would prefer a penoscrotal incision because it gives a better exposure. It gives better exposure of the proximal crura. Under vision, put the scrotal pump also. And the only disadvantage probably is that if there is a history of previous pelvic surgery, it is because the reservoir has to be put blindly, it could be difficult. So the other approach, which is the infrapubic approach, where you can actually almost under vision put the reservoir, would be beneficial in that case. And particularly even if there is a revision of surgery, probably the infrapubic approach could be beneficial. And if you are putting a malleable processes only, sometimes people would do a subcoronal approach, that could be also used. And even if the patient is an obese patient, definitely then again a penoscrotal approach is more helpful.
Okay, thank you, sir. So this is again what the data says. The ones you see the green bars. So the most commonly done approach is the penoscrotal approach, and only except in Netherlands and Belgium they tend to do an infrapubic approach. But most of it is the penoscrotal approach. And yes, so the sharp penile processes is of course the most commonly done processes in Indian scenario because of the low costs, and also that most of the insurance companies do not approve any penile processes surgeries. So we need to know how to optimize results with the sharp processes. Dr. Rupin sir, if you could please take over the next few slides.
I think the most important thing to realize with the SHA implant is that it's being non-inflatable. It has to depend on some mechanism for concealment. The AMS was a malleable in which there was a steel wire inside. So when you bent it, it stayed down. The SHA implant is actually a differential rigidity implant, or to simplify it, a hinged implant. So the anterior portion of the implant, which in the picture you see as dark blue, is stiff and gives rigidity to the shaft of the penis. The central gray area, yeah, you could take the cursor there, yeah, that is the hinge, which is 5 centimeters long. And we want to place the center of the hinge at the symphysis so that the anterior 2 centimeters will protrude in front of the symphysis and give flexibility, and the remaining 2.5, 3 centimeters will head into the crust to give stability. And the end portion of the implant is trimmable to adjust the implant to the total length of the penis. Now, since some penises are short and some are long, but we want the hinge to be in the same location for every case, we need different models of the implant where the anterior stiff zone is variable. So for example, this picture which you're showing is the WH9. WH means with hinge, and 9 refers to the stretched penile length from symphysis to mid-glans. So if the stretched penile length is 9 centimeters, you will choose model WH9, in which the anterior 7 centimeters is stiff, and then the proximal 2 centimeters will have a hinge action. If you take WH11, which is for a longer penis, in WH11, the stiff zone is 9 centimeters long. So that once again, if the stretched penile length is 11 centimeters, the anterior part will be stiff and the hinge will occupy the proximal 2 centimeters. If, on the other hand, someone's stretched penile length is 13 centimeters, then we would use WH13. So the number refers to the stretched penile length, not to the diameter of the implant. We need to be clear about that. So in WH13, once again, the hinge has to be at the base. So the stiff zone is 11 centimeters long. So that once again, the hinge will lie 2 centimeters in front of the symphysis and the rest in the cross. And finally, for a very long penis, you would select WH15. So if somebody's stretched penile length is 15 centimeters, WH15 has a 13 centimeter stiff zone anteriorly, and then the hinge as usual. Now, one additional point to bear in mind is that these long implants, WH15 and WH13, have a diameter of 15 millimeters, but these implants have 2 removable sleeves, which is unique. It's the only implant in the world with 2 removable sleeves. If you remove one sleeve from the WH15 or the WH13, the length, the diameter will reduce to 13 millimeters. And if you remove both the sleeves, the diameter will reduce to 11 millimeters. The shorter implant, which is WH11 and WH9, come with a diameter of 13 millimeters. And if you remove one sleeve, 13 millimeters will become 11. And if you remove both sleeves, then it will become 9 millimeters. So by removing one or both sleeves, you can ensure the optimal fit in the corpora, because one very important difference between the non-inflatable and the inflatable implant is that with the inflatable, you can just push it in and the implant will then expand to fill the corpora. With the non-inflatable, you don't have that luxury. So at the time of implantation, you should try and get the largest possible diameter in. That will give the maximum stability to the penis and the best functional result. So by selecting the right model, we have to achieve a balance between adequate stiffness and adequate concealment.
Thank you for the detailed explanation, sir. So we'll move on to the next discussion. So when we are doing a penoscrotal approach, this question is to Dr. Garafa. Suppose during the initial dissection, before the corporotomy, if you injure the urethra, so what would be the next step? Should we just abandon the procedure or can we proceed?
Well, that's $1 million question, because to be quite honest, if you have not touched the corpora, if you repair the urethra and you close everything, you will be able to come back in a virgin tissue in the corpora without any fibrosis a couple of months later. On the other hand, if you repair the urethra and then you do the implant, if there is going to be any leak of urine, the leak of urine will be at the level of the tubing, so it will get infected. So if you are 100% sure that you are able to repair the urethra in a watertight fashion and leave a catheter in for at least 3 weeks and until a pericatheter ureterogram shows that there is no leak whatsoever, then you should be better abandoning it. I personally, if it was one of my patients, I would repair the urethra, leave a catheter and come back a few weeks later. It would be different if I've already done a dilatation, because that side that has been dilated, if I don't place any device inside, will heal with scarring, which will cause shortening. So the penis will get shorter. There will be fibrosis. When I will try to dilate again, the chances of complication in terms of distal urethral perforation, proximal perforation, crossover will be much higher. So in that case, the situation is different. In that case, I would rather put a malleable. If you want to, if it's a private patient and you don't want to take him out of theater because that will be at your cost, and you have to implant a penile prosthesis and you've injured the urethra and you are confident you've repaired it,
then opt for a malleable device, because with a malleable device, then you can close the corpora in a sealed fashion without any tubing or any structure that can get infected. Or better, you repair the urethra, close the close the scrotum, and do a subcoronal approach, so that you will be working into completely different compartment.
Okay, thank you, Dr. Garafa, for that.
If it's a distal perforation, the situation is different, because in a distal perforation, by definition, the fossa navicularis is contaminated, and most of distal perforations are at the level of the fossa navicularis. So ideally, if it's the first side of dilatation, you should abandon the case. If you have already dilated the other side, and then during the second dilatation of the second side, you have perforated the fossa navicularis, you should leave a malleable on the side that is not perforated to preserve penile size, and abandon the procedure. There is no point to repair the urethra. The urethra will repair by itself. Just leave a catheter until a pericatheter urethrogram shows no leak.
Okay, thank you. So, and the other important thing is that when you're putting the dilator in the proximal corpora, you need to be aware of the direction of the crura, which goes slightly laterally. And if you put it directly below, and there is a chance that there can be a tear or the tunical perforation. So you need to know the angle of the corpora. And Dr. Rupin sir, what would you do if there was a proximal corporal perforation? What was done a decade back, and what is done now?
There are two different approaches based on whether you're using a non-inflatable Shah implant or whether you're putting an inflatable implant. One of the unique features of the Shah implant is, since it doesn't have a steel wire inside, is that you can cut it at any point and take a stitch through the implant also. So if I was doing a proximal dilatation and I had perforation, and this typically happens about 2 centimeters proximal to the tip of the crust, because it tends to be a narrowing at that region, then I would check the point of perforation, shorten the implant so it falls short of the perforation, hold it in place and take a stitch through the tunica and the implant and fix it in place, and the perforation would seal itself. If you're doing the inflatable, then of course you can't take a stitch through the implant. So previously people used to fashion a windsock using a proline mesh, but that would dramatically increase the possibility of infection. So any mesh is a bad thing with an implant. So instead, now what is done is the rear tip extender, which is placed at the proximal end, is used to support the implant. So you take a stitch through the tunica and the rear tip extender to create a sling and tie that, so that will prevent the implant from migrating proximally, and the perforation will close. Obviously, then you have to place the implant in the right plane and short of the perforation.
Okay, thank you, sir. So we need to be aware of this tunical, this corporal coning in the glands. So when you are dilating or even you're placing a malleable implant like a Shah, there is an option that in the Shah prosthesis that you can do a selective sleeve resection at the tip of the in the gland, so that it can accommodate properly without causing the distal perforation. And Dr. Shivam sir,
yes.
what would you do with when your resident sends this picture to you on a WhatsApp from the emergency room?
So obviously it's a case of cylinder extrusion with distal perforation. So this usually happens because on the ventral side, the tunica is quite thin. And if you do an aggressive dilatation or oversize the cylinder, or sometimes put a cylinder in a narrow cavity, then this can happen. As Dr. Rupin said, that with this SARS processes, you have the option of putting out the sleeves also. So particularly when there is a narrow distal corporal body or near the glands, then you can even remove the sleeve and exactly fit them without oversizing. So that can actually help them. In this case, definitely we have to remove this extruded implant. The options are either remove both the implants, or you can just remove the extruded implant and keep one implant as such. And the other option is that you remove this extruded implant and wash it with antiseptic solutions and then do a corporoplasty and put a new implant on this side. So these are the three options which are available.
Okay, the most commonly mentioned in most of the literature studies about the salvage protocol is what is described from the Mulcahy. Of course, there is a cocktail of antibiotic solutions that are used for the corporal washes in case of infection. And the usual thing that is done is when an inflatable gets infected, you use all this cocktail of antibiotic solutions, and then you tend to leave a malleable implant and usually not a inflatable implant. And then maybe 3 months later, when all the infection has settled, then the patient may be taken back for an inflatable implant. That is usually the practical approach. And yes, so Dr. Hota sir, so what would you do if you see this patient in your outpatient department? Basically pus coming out from the distal part of the penis after the prosthesis.
This is the most difficult part of the whole procedure. In fact, the prevention is cure. Always we should see that such situation doesn't happen. I'll come to that beforehand. You know, when such a situation comes, then definitely we are in problem. And what will be our approach to such patient exuding pus? Now we should go for a culture of this. We start the antibiotic before that we go for a culture sensitivity test of the pus. And we give a broad spectrum antibiotic covering both gram-negative and gram-positive combination. Now, as per the culture sensitivity, we should appropriately start the antibiotic once the culture report is available at our hand. But however, if you look to the literature, that many of the time, around 50% of the time, once the prostate is infected, many a time, 50% of the time, it is very difficult to control the infection, and we may have to explant it. You know, we have to remove the implant. Now, but what would be my suggestion that instead of having such a situation, we should try to prevent an infection, and the prevention start right from the before we plan the surgery. Now we should look to the patients, you know, what are the conditions he's harboring, like any comorbid conditions like diabetes mellitus, does he have an immunosuppressed condition? And we should also have a look at the local examination for any ulcer or any infection patches. So we have to prevent that before we contemplate the penile prosthetic surgery. The other aspect that we should look to for a penile prosthetic surgery is that we should make the part preparation with chlorhexidine or povidone iodine prior to surgery, and during the surgery at least a 10 minutes scrub of the private part. And we should right from the umbilicus up to the mid thigh, we should be thorough cleansing for 10 minutes. And we should always appreciate that a no-touch technique. I think that is the best way we can prevent the infections, utilizing a sterile room. When Dr. Saha had come 25 years back, at that time we had not realized. In fact, he was very skeptical about our OT room. I would like to remind that. No, but over the time, what we have realized over the time, that, you know, prevention of infection is the most important thing, and utilizing the best available antibiotic, because, you know, the staph is a major organism for the infection. A combination, what we were using earlier is vancomycin with, you know, netlimycin. Now we have switched out to linezolid and netlimycin, that combination. This is what we have to prevent. But once we have such an infection, then definitely we are in problem. Salvageable as far as possible, we'll salvage it. If it is not salvageable, we have to explant it.
Yes, if I can add something here, Pramod.
Yes, sir.
Yes, sir.
Yeah, I think, you know, we read about salvage, we talk about salvage. A implant with pus pouring out like this, there is no question of salvage. And I would not even wait for the culture report. This implant has to come out very simply. And the thing is, once the implant comes out, actually the infection will settle down. And if it is an inflatable, you have to remove all the components. Steve Wilson said that you salvage implants when there is a wimpy infection. That is the term he used. And by wimpy, you mean it's not come up rapidly within a few days after the surgery, and the discharge is thin, watery, and not deeply purulent. If you try and salvage a case like the picture you showed, the salvage is going to get reinfected. Guido may like to add something with his experience.
Thanks, Rupin. I wanted, first of all, to underline what you said is very important. There are some important factors, two red flags which will say patients cannot have a salvage. The presence of pus, the presence of skin perforation, the presence of redness, the presence of sepsis or unstable diabetes. So it's for wimpy chronic infection in which the patient complain of subtle pain at the level of the cylinders or at the level of the pump. Those are patients who will do well with salvage. Patient with acute infection, redness, swelling, wound ascents, skin necrosis, sepsis, or pus, then those patients shouldn't be managed, should be explanted and left them be and come back at a later stage.
And nowadays, how many months later would you prefer to operate?
Well, that's a good question. The more you wait, the more shortening you will have in the penis. So ideally, you should wait a couple of months, probably 2 to 3 months, not beyond the 3 months, because after that there will be severe scarring and shortening.
Okay, do you, Garafa, do you leave a malleable implant by giving a wash, whatever the Mulcahy protocol or something like that? Or you just take out the implant totally? If it is an
okay, if it's amenable for salvage, you have to remove, first of all the implants. So if it's an inflatable, all the components need to come out. In theory, for Mulcahy salvage, you should replace inflatable with inflatable. But I personally would rather place a malleable device and then a couple of months later exchange it electively to an inflatable, because the malleable will maintain the space. It will be easy to remove it and place a new inflatable afterwards without loss of any length.
But Pramod, not for this case which you're showing. In this case, you will take out the implant and not put even a malleable inside.
This one is to be removed and abandoned and come back a couple of months later.
Okay, but again, the surgery next will be, I guess it will be very difficult because of the extensive corporal fibrosis. So that is another.
But is the less of the problem. If you implant him again, he's gonna get infected. You will take him back to theater with a more vascular complication. He may experience glands necrosis, penile skin necrosis. So I understand it will be much more challenging, but it will be the less of the problems.
Okay, so the conclusion is just remove the implant if a patient
in this
comes.
case, is not salvageable.
If permitted, can I have an observation?
Yes, sir. Last one comment, sir.
Yeah, observation. Well, we are all the time thinking this is infection of the prosthesis. Could this be a subcutaneous infection as well?
Only in the case that this patient has had a penile implant and then he had a degloving at the same time. In that case, it's possible that there was a hematoma under the skin and that got infected and is in a separate space from the implant. But I think this is a very, very remote possibility.
If you look at this picture, possibly he has undergone a circumcision as well at the time of prosthesis surgery.
Yes.
So that was the only point I was trying to,
Yes, you cannot generalize. Every patient should be taken separately. You cannot also rely on the picture. You need to see exactly which operation he had, what's his overall well-being, because if the patient that you see there is septic, has 39 of temperature, and has rigor, then certainly is different. So you need to, in common practice, if you have redness, which he has hyperemia of the glands, he has swelling, he has purulent discharge. These are all red flags. Then you might have an exceptional case in which he has a subcoronal abscess, which is separated from everything else, which I've seen only once in my life, in a patient who had a penile disassembly and modeling so basically he had a combined degloving, and this was in a separate space and was managed, salvaged with antibiotic. But this is the only single case in 20 years that I've seen.
Okay, thanks for the discussion. We'll move on to the next slides. So since we are short of time, we'll just skip some of the slides. Dr. Rupin sir, all these Concord effect deformities should be repaired, or some of them can be left alone?
So there are many aspects to this. One, some patients are able to pull the penis backwards at the time of penetration so that the implant moves into the glands. and then they're able to have intercourse. So it all depends on what caused the concord. Was there incomplete dilatation? Was the implant too short? Were the tips of the corpora fibrous, therefore the implant couldn't go there? And depending on that, some can use maneuvers to achieve intercourse, some need replacement with a longer implant, and some will need a granulopexy.
Okay, I think sometimes when the patient is not very bothered, I think some of these concord defects can be left alone without any surgical interventions.
So there you tell them to just pull back the skin,
Yes.
and you'll be surprised that that will pull the glands onto the implant, and then they'll be able to achieve penetration.
Okay, okay. Since Dr. Ramaswamy, Ranjit has spoken about the Peyronie's disease, just one answer from all the panelists. What is your preferred graft when you're doing a penile prosthesis and a grafting procedure in a Peyronie's disease with a refractory ED? Rupin sir, your preferred graft?
So we used to use, we've used many things. I used saphenous vein for a long time. And if it's a small defect, then saphenous vein still works. It doesn't cost the patient. We used to use a 4-ply cis from Cook Surgical, but that's no longer available. The good news is that bovine pericardium is now being manufactured in India by a Chennai-based company, and we've used that in 3 patients with good results. So currently our preferred material is bovine pericardium. Tutiplast is what is available from Coloplast, and that has long-term follow-up in literature. So the same Indian version is now available. It's called Syncraft.
Okay, okay. Dr. Shivam sir, which is your preferred graft?
I feel I would prefer an autologous graft rather than a synthetic, because I feel the implant with the synthetic graft, there's a chance of more infection. So if I can get tunica on the opposite side or from the crura, or even a dermal graft or a dermal flap, I would prefer that. If I don't get, then definitely we would put a synthetic graft. Some people even do not put any graft, and many of these patients are satisfied without the graft also. So I don't know about that, but this is my preference.
Okay, my one concern is that considering religious sentiments in India, most of the pericardial grafts are of bovine origin. So if you're putting this graft in a Hindu patient, the other graft is the small intestinal submucosal grafts, which are of the porcine origin. So just make sure that you counsel these patients before. If you're putting a porcine graft in a Muslim patients, again, there can be some issues because of the religious sentiment. So just be careful while choosing the grafts. Okay, so next.
I think Goelo would like to talk of the collagen fleece.
Yeah, that is what it's shown in the picture, the taco-seal. The taco-seal graft is currently not available in India, although very extensively used in US and Europe. And in fact,
Pramod, we have it in our hospital, so maybe it's available. And it costs only 5,000 rupees, yeah.
Okay.
Okay, that's good.
Listen, first of all, you have to appreciate it. You don't always need to graft, because instead, in this patient, instead of making that incision, you have done multiple vest kind incisions, and the defect would be less than 1 centimeter in each one. You wouldn't need it, because then the Bax fascia would produce adequate seal. If you need a graft, is not the reason. If you use allograft, there is no increased risk of infection. Only if you use a synthetic graft, like for example, the Dacron, then yes, you have a 20-30% increase. Well, actually, no, you have a much higher than that increase, because your infection rate is 20%. Well, naturally would be 1%. So it's much higher infection rate. I know in India there is a question of costing. Why don't, obviously with the saphenous vein, the limiting step is A, you need to make a second incision. And second, if the vein is flimsy, then you need to get a very long vein and cut it and add it together. What about, you see from the subcoronal incision, you basically reach the scrotum. What about if you flick out one of the testicles from the scrotum and you remove the tonaca vaginalis and you use the tonaca vaginalis as a graft? I've used it only once when I was in Indonesia to do live surgery, because over there they didn't have any other graft, and actually worked. And it's quick. You don't need to do a second incision. Okay, you have only to waste the time for the quilting of the graft, basically suturing all the edges. The advantage with the Tacocil is that you don't need to do any suturing, and is hemostatic and avoid the need of the suturing, so it's quicker, but there will be a cost for you. While the thoraca vaginalis is there, unless the patient has had the previous scrotal surgery, a hydrocele repair, is there for you to have, and is by definition is sterile.
Okay. Okay. Coming to the penile dressing post-operatively, I somehow find this Coban dressing very helpful. So your comments, Dr. Hota sir, your comments on this?
Yeah, the dressing that you have shown, I think that replicates what is Coban dressing is concerned, which is the important aspect after the completion of the surgery. No, Coban is nothing but a lightweight, two-layered cohesive elastic, which doesn't stick to the skin; they stick to itself. No, the utility is so good as regard the post-operative outcome, prevention, hematoma, and giving a good completion. So the primary objective is that there should be no skin sticking. It sticks to itself in two layers. There is also a foam surface. The inner layer has a foam surface, outer layer is adhesive. So I think Coban dressing is one of the best dressing. But what we have been doing practicing, we are doing a Coban-like dressing. We using the elastocrepes. So that is what we have been using, and I believe this dressing is quite useful. Unless we are doing an inflatable one where we have got this handy mummy wrap, or we have got one color. So for our practice, we have been using, may not be the exact Coban dressing, but we are doing the Coban-like dressings.
Okay. The elastocrep may leave some of the plaster marks.
Dr. Pramod, can we just wind up, because the discussion is getting interesting, but we have already exceeded 20 minutes. So can we wind up?
Yes, sir. Yes, and the other aspect is, Dr. Rupin sir, if you could tell me what is your experience when you had to leave a single cylinder in your personal experience?
So we've had cases where we could place only one implant, and we've had cases where patients have come with late erosion without any obvious signs of infection, where we've removed one cylinder. And surprisingly, we now have a fair number of patients who have only one implant in place, and they're still able to function adequately. It's not as good as two implants, but certainly adequate for function.
Okay, so the last aspect would be about the reservoir placement. Dr. Garafa, what is your preference at what level do you place the reservoir? Because this is one of the most scariest part for the novice implanter. Initially, before placing a reservoir, below the transversalis fascia was the norm, but recently ectopic location is the most preferred one, which is placing the reservoir between the transversalis fascia and the rectus muscle. So what is your personal opinion and the practice that you do?
Okay, thank you very much for the question. Well, first of all, you need to see if you have a lean patient, then doing ectopic placement of the reservoir above the fascia transversalis, then you will probably have a reservoir which can be palpated or seen if the patient is very lean. So if a patient is overweight, then very often this will not be a problem. In the paper or from the slide you showed before this one, in that series, it was a cadaver series in which they placed 20 ectopic reservoirs. And basically what they show is that it is extremely difficult to place in the correct position the reservoir in the ectopic place. And in most cases, the reservoir migrated or was located in a different position. So this is something that's very important to keep in mind. Typically, what I do is I place the reservoir in the ratio space. Very often I don't put a catheter because to me it takes 30 minutes to do the implant, which means after 25 minutes I'm placing the reservoir. So by then, if the patient has emptied the bladder before going into surgery, then the bladder will be still empty because but if you are a novice implanter, then you need to make sure the bladder is empty. So and since it's going to take longer to do the procedure, you will need to place a catheter and make sure you empty the catheter and change the gloves before you place the reservoir. if you do it ectopically, then you don't need to empty the bladder. And ideally, ectopical reservoir should be considered only for patients who have had previous pelvic surgery, because then the rescue space wouldn't be present, and therefore the risk of injuring either one of the viscera then would be too high. So I wouldn't risk. There are some colleagues that say they place it ectopically, they place blind position in the rescues in patient post robotic prostatectomy, but it's not something I would do, because we don't know what was done in the previous prostatectomy. You don't want to risk of an inadvertent perforation. So I would say for any patient who had previous pelvic surgery should be ectopic or second incision. Patient needs to be warned about the possibility that if they have it placed ectopically, they might palpate the reservoir. Most of them, they say, I prefer to have a palpable reservoir rather than a second incision. But it's something you need to discuss with patients.
Okay, thank you, Garafa. The last question would be to Dr. Hota and Dr. Shivam. What are the challenges that you face in starting a penile prosthesis program in a medical college, since you both of you are in the prestigious medical colleges? So just a 30 seconds opinion on this.
Yeah, the first challenge, I would always say that challenges of self-challenge, accepting that andrology is a specialty oneself, thanks to the USI that now we have got a andrology sections which is growing very fast. Earlier, Dr. Rupin used to say that, andrology has to be propagated, and he was the pioneer in that. We are thankful to him. In fact, for him, we have all been encouraged. The first challenge is having, our society is a very conservative society, and they do not want to speak about their sexual problem. So to bringing awareness and to start a setup, we should have more emphasis on IEC, information, education, and communications, through different social media, different media. Now, unless in our curriculum we introduce that andrology is a specialty, sexual dysfunction, erectile dysfunction is a specialty, we have to think of changing the curriculum. Third, which we have been trying now. And third, opening dedicated andrology clinic. I have opened a dedicated andrology OPD in my department. We have all the armamentarium for andrology practice, and that has helped us. Now, our average andrology OPD patient is about 30, but it has taken more than a decade. I hope we can always introduce the andrology clinic in every government setup at the earliest.
Okay, thank you. One last comment from Shivam, sir.
Yes, it's difficult because Dr. Hota could open the andrology, but because of the bureaucratic administrative hurdles, it is not very easy to open an andrology clinic in a government teaching hospital. Secondly, because of the financial constraint, most of our patients are treated free. We cater to a lower socioeconomic status. So usually these patients who need penile implants do not come to us, and they would, if they can afford penile implant, they would go to higher center or private corporate hospitals. And thirdly, because of the government hospital and the wards and the poor hygiene, sometimes we are quite scared of the post-operative infection in these patients. So I think these three things are important challenges to us.
Okay, so I thank all the panelists for their wonderful personal insights into this discussion session. Yeah, no,
Thank
yes.
you, Pramod, for this very informative panel discussion. And I would just like to get few comments from Dr. Rupin Shah regarding the andrology session, and with that we'll wind up and hand over the sessions to Dr. Rajiv.
No, I'd like to compliment you, Dr. Vinod, and the USI for having a special andrology webinar. As Hota has seen over the last 25 years, and so has Shivam, 25 years ago, we had to struggle to get andrology noticed. Nowadays, more and more young people are coming. Pramod, who did such a wonderful job managing this last symposium, and many other young andrologists are coming up, and I'm sure that andrology in India will have a bright future.
Thank you, sir, and I personally thank all the faculty who has participated and all the members who have attended. And I also thank Dr. Ranjit and Dr. Garafa who have accepted our invitation and
Thank you very much to everybody.
Here.
Thank you very much.
And we are really sorry that we extended our discussion for 30 more minutes. And with that apology, on record, I hand over the sessions to Dr. Rajiv for his conclusion.
Thanks, everybody.
Thank you.
Thank you.
Thank
Thank
you.
you.
Really, it was a wonderful webinar. Common conditions which one come across in the andrology practice were touched upon very nicely. All these speakers done an excellent job, giving an excellent and crisp talk, focusing on the practical aspects of the condition. That was one of the major thing I have noticed in these talks. And to add flavor in the end, the panel discussion on penile processes and various associated complications with prosthesis surgery was really interesting. We could have continued for some more time because of the shortage of the time. Like I had to request Vinod to cut short it, because this panel had eminent andrologists from international side as well as our legends, Indian legends, Rupin Shah and others, who are giving their expert opinion. And to notice, it was to my surprise, we had around 294 viewers on Facebook and 176 viewers on Zoom, nearly touching upon 500 viewers. It's wonderful. And this shows the interest of the practicing urologists in the field of andrology, which we were highlighting 25 years back. It was a very hard struggle to focus the subject of andrology. I, on behalf of the Council of USI, express thanks and gratitude to the international faculty, Gulio Garafa and Ranjit Ramsamy, and our Indian legends, none other than Rupin Shah, Vasan, Vineet Malhotra, Hota, and our young and budding andrologists were taking a lot of interest. Vinod, Pramod, Shivam, and Raman, all have done an excellent job. And I thank from my heart all the speakers and all the participants from India as well as from other SAR countries for making this webinar a grand success. Thank you all once again.
Thank you.
Thank you.
Good night.
Good night.
Thank you. Thank you, everybody. Good night. Good night.
Good night.